Well, welcome everybody. This is an exciting time. As you know, uh, Larry and Matt called me up to a meeting up to Trumbull Memorial, and we sat there talking about some EMS issues, and and I said, we need to put together a continuing ed, and these guys jumped in with 2 feet, um, and Matt graciously offered Trumbull Memorial Hospital as the host, and Larry was, has done a tremendous amount of work in the background getting things set up. So, and again, this is being done in collaboration with Youngstown State too. So, what I'd like to do is now I can't see. All I'm seeing is my presentation. I can't see anybody on the chat, and so what I'm going to do is I had, last night talked to Larry and Matt and said that, if people are raising their hand, they're going to go ahead and kind of facilitate this. Feel free to ask questions, but I got a lot of material to cover tonight to get through to meet the NCCP, guidelines. You know, but feel free to ask a question. If you have a question, you don't have to wait till the end. You can raise your hand, and then Matt or Larry will go ahead and put your question in the. Actually, the easiest way to do it is put your question in the chat box. That's the easiest way to do it. Type it out in the chat box, and we'll get to it. It's a learning event. It's a lifelong learning event, and I'm excited to be part of this. So, one thing I do want to preface also is saying that. So, in last night we talked about this. That this lecture tonight, a lot of people go back and say, "Well, geez, this is like foundational stuff," and it truly is. But one thing I tried to do is link everything clinically, so it makes more sense to you clinically, either in your assessment of the patient or in your management of the patient. And so that was one of my goals, was to actually make this become relevant to the practicing provider and not a student just learning this. Whether you're an EMT, an advanced EMT, or a paramedic, this is all relevant. This is all part of the National Registry's NCCP curriculum. So there's absolutely nothing in here tonight that is not relevant to an EMT. This is all relevant to all 3 levels. And we're going to focus on some things, that maybe you've been taught. I notice there's some people that, are out there that have been out there for quite some time, and there's some things you may have been taught that is no longer true and has been through evidence-based medicine has been removed as a standard practice and so forth. So we'll talk about that too. So, the most important thing on here is 2 things. One, I'm retired. I've been retired since June 30th of 2020. And my email address, it's still current at YSU. And if anybody has any questions or anything, if anybody wants a copy of this PowerPoint, I could put it up on my Google Drive, and I'll send you a link, and you could go there and pull it off if you'd like. If you want to use this as a continuing ed for your, department or something, feel free. I'm all about sharing, information and education at this time. So, all right. So again, I do want to preface this by saying this is all part of the National Registry's NCCP curriculum, where this is the first curriculum that they did of this type. And a lot of it has to do with foundational information that they feel that, some people are lacking. So, but again, I will make this clinically relevant to you. So talk about the good old days, pretty much before 2005. And that, seems like, wow, that wasn't that long ago, but actually that was quite some time ago. And, one thing that a lot of people learned back in the day before 2005 was, for the most part, oxygen was good. If you look back, you say give as much oxygen as possible. I remember in the early 80s working full time as a paramedic, and we'd bring in a non-breather, and they would draw blood gases. They'd run the blood gases, and they'd get PaO2s back of like 600, and we were like, slapping, hand slapping and chest bumping and everything. We thought we were doing such an awesome job, because we actually created this exceptionally high. Whoever's got their mic open, can you close it, please? Can you shut your mic off? Thank you. And so we were, oxygenating the hell out of these people back then. If you guys remember the old DOT 1994 EMT curriculum, everything that was done was the patient got a non-rebreather. And I used to laugh. It was, virtually very little assessment, basically no treatment other than a non-rebreather. But everybody got a non-rebreather. It's like, so you arrive on the scene and say, so what happened to you, ma'am? Well, I stubbed my toe on the couch. And be like, okay, well, all right, let's put her on non-rebreather and let's transport her. And then, next call, I'll be like, so what happened to you, sir? Well, I cut my arm off with a chainsaw. Okay, let's put a non-rebreather on you at 15 liters per minute. Let's take you to hospital. I mean, what happened? I think she had a stroke. Non-rebreather, 15 liters, take her to hospital. Everybody without any use of any SpO2 monitoring or anything, everybody got maximum amount of oxygen. Well, that was before 2005. In 2005, the American Heart Association, through their research, found that, O2 actually is causing some tissue damage, a lot of tissue damage in some conditions. And that's when they started to realize that oxygen actually could be hazardous in some conditions. And that's when they started to focus much more on, regulating the amount of oxygen that's given to patients, especially patients were reperfusion injuries like stroke or MI or shock or whatever it would be. The other thing too was, the more you ventilate, the better off you're going to be. And I remember the old days, again, we'd have the patient intubated that was in cardiac arrest or that was in respiratory arrest. And, as soon as that bag would refill, we'd ventilate. And I even remember teaching this, that, you use both hands and you squeeze every bit of air out of that bag, out of the BVM. And, so we were trying to deliver the most volume that we can to a patient. And we say, every time that bag refills, you ventilate it because air is good for this patient. Because if you're delivering air, you're delivering oxygen, and oxygen's good. There was one study they did, and they found that most EMS providers in a cardiac arrest, on average, bag the patient 48 times a minute. And if you think back to your calls that you had, you'd be like, well, 48 times a minute. And if you think about it, especially if the patient was intubated, think about it. You watched everything else going on, and you were the person that was responsible for the airway and ventilation and oxygenation. You hooked it up, you put it on 15 liters per minute by a reservoir to the bag, and you sat there and you're watching everything going on. And as soon as that bag refilled, you squeezed it, you squeezed it, you squeezed it. And on average, EMS providers were ventilating 48 times per minute. And this was done through observational studies. We'll find today. Again, if you have your mic not muted, can you please mute your mic? I think it makes it tough for everybody to hear. Thank you. But anyways, we'll find that, ventilation, more ventilation is not good. Actually, Larry had sent me some recent information. I know that, Matt, I'm not sure if you could mute everybody's mic. Okay, maybe that did it. All right, thank you, Matt. But Larry and Matt both, and Matt's going to talk about it towards the end. I put some of the slides and some of the latest research out there on ventilation, but I'm going to provide you the physiology behind the overventilation and how this actually turns out being really bad for the patient. So, as EMS providers today, we really have to focus on using the least amount of oxygen as possible, and also ventilating with a reasonable rate and a low tidal volume, typically the lowest tidal volume, that'll produce the results that you want. And we're going to talk about all that too. So, and again, you look at this and say, yeah, it's wrong. All this was wrong. Squeeze the bag to get the most air out, ventilate as fast as you can with as much air as you can, and give as much oxygen as you can. Those are all wrong today. And if you're doing those things, actually, you're harming your patients, because again, through the, evidence-based medicine and so forth, they're finding that, patients' outcomes are being impacted by these practices, and it's not good, especially neurologically. So, these are things that you really have to be cognizant of. But one thing I want to tell you is, we all know in the heat of the moment on a scene of an EMS call, especially a pretty dramatic scene, sometimes you're not aware necessarily of what you're doing, and you may be ventilating at 30 times a minute, or whatever it might be, 24 times a minute. And I'm going to tell you that is so detrimental to the patient, a shock patient, a cardiac arrest patient, very detrimental to the patient. You have to be very, very aware of what you're doing, ventilation and oxygenation. So that's some of the stuff we're going to focus on today too. So also after 2005, what they found was, again, the hazards with O2 administration, hazards with overventilation, and specifically with rate and tidal volume. So overventilation, remember, there's two components to ventilation. That's the rate at which you're delivering the ventilation and the volume, the tidal volume, the amount of air that you're actually using to ventilate the lungs. And they found that there's hazards with both, creating a situation of overventilation. And we're going to talk about, those in particular, and also especially the effect it has on perfusion. And you say, well, what's the relationship between ventilation and perfusion? They're two totally different systems, but there's a direct link between ventilation, especially overventilation, changes in intrathoracic pressure, and coronary artery perfusion, cerebral artery perfusion, and perfusion in general. And I'll explain that to you. All right, so I know you're going to look at this and go, oh, geez, I learned this in 10th grade biology in high school and thought, I would never use this again in my lifetime. Why are you going to talk about this again? But this is essential, because one thing I'm going to tell you is, for the most part, your entire treatment focuses on the next few slides. Everything you do in EMS, every treatment you provide in EMS focuses on cell metabolism, believe it or not. And if you understand cell metabolism, I'm not going to go into detail, for God's sakes. I know Dave Yash is on this call, and Dave's going to go, that's all you got, Joe? Dave's, has close to a master's in biology now. And I'm like, yeah, Dave, I'm going to provide a pretty elementary description of metabolism. But what I want to do is really get the concept across and actually apply it clinically, and why this is extremely important. So we know one thing: ATP is energy. We know that energy is necessary for cell function. So in order for a cell to function normally, you have to have an adequate amount of ATP. So it's as simple as this. If you have a patient and you arrive on the scene and the patient's awake, okay, so they're looking around, but they're not aware, then one thing you have to ask yourself is, are their brain cells getting enough or producing enough ATP to keep them awake? Well, if they aren't, then what you're going to have is you're going to have an abnormal neurologic response, and that might be an altered mental status. You say, well, how does a person become unconscious? Well, they become unconscious because for some reason those cells are not producing the adequate amount of ATP for whatever reason. Is it an oxygen reason? Is it a perfusion reason? Is it a toxic reason? Whatever it would be. But their brain cells are hypoxic, or their brain cells don't have the glucose necessary to produce enough energy, and it shuts them down. Okay, so ATP is extremely important to function. All right, so here again, trust me, this is not going to be a test question like, how many molecules make up the pyruvic acid? That's not it. But there's a couple things that I want you to understand in here, and then again, I'm going to relay this clinically to you. So this is metabolism, okay? Glycolysis is the first part of taking a glucose molecule. Okay, lysis means to split apart, right? To lyse something, it means to split it apart. Glyco is referring to in this process a glucose molecule. So you take a glucose molecule, you put it into a cell membrane, and the first step is glycolysis. And that means you're going to take that glucose molecule, you're going to split it apart, and you're going to split it into these two pyruvic acid molecules. Okay, great. I don't care if you leave this lecture, you never remember again that that's pyruvic acid, whatever it would be. But one thing that I do want you to remember is, though, when you put a glucose molecule into the cell, you produce two molecules of ATP. And we already know ATP is energy, right? And so by just putting the glucose into the cell and splitting it, you're producing a little bit of energy. Now, the interesting thing about this is this process is an anaerobic process. That means that your cell doesn't need oxygen in order for this process to occur. So what does that mean? even if the cell isn't getting an adequate amount of oxygen, what's happening? Well, as long as glucose is available, while the glucose gets in the cell, you're still producing a little bit of energy. And this is very important when you talk about how a cell dies. So the most important thing here is put a glucose molecule into a cell. You don't need oxygen available. This first process is anaerobic, and you're producing a little bit of energy. Okay, not a lot of energy, a little bit of energy. Not enough energy to run the cell normally, make it function normally, change its structure, but enough to just keep it alive for a period of time. Now, the next thing, those pyruvic acid molecules now enter into what we would know as a citric acid cycle or the Krebs cycle. Something you learned again, and here's the whole process, you know, acetyl coenzyme A and oxaloacetic acid and so forth, the whole thing. Well, what I want you to remember here is one thing is this is an aerobic process, meaning this process, in order for it to occur normally, requires oxygen. Oxygen has to be available. So the glucose gets into the mitochondria, or the pyruvic acid gets into the mitochondria, but in order for this process to occur, there has to be oxygen available, okay? And notice also there's this electron chain, and you see if you see my point is high energy electrons keep being transported down this high energy electron chain, and this is where you're actually getting this big bang for your buck right here. You're getting about 32 to 34 molecules of ATP being produced. You add here 2, you add here 2, and at the end it's about 38. It's kind of funny. Larry could tell you about this probably for hours, about how they keep changing this, and some references will say, well, no, there's only 34 molecules of ATP. Some say 36, some say 32, some say 38. Doesn't matter. Here's the bottom line. Here's what we know. There's a lot of energy that's being produced when you put pyruvic acid into the mitochondria and you add oxygen and you allow these high energy electrons to go down their chain. You're putting oxygen in there in this electron transport chain. And what do you come out with? A lot of energy. Okay. And there again, what you have to understand is you have to have oxygen available in order for this to happen. So look at this. The most important thing is what's in red. So what is the byproduct of the electron chain transport? Again, you have to have oxygen available. You obviously have to have glucose available too, because you didn't have glucose to put into the cell, none of this is going to work. But you have to have oxygen available. You say, okay, so what's the byproduct? When you have oxygen available, an aerobic process, you have glucose available, the bottom line is this. That cell is going to produce 32 to 34 molecules of ATP, 38 in total, okay? Another byproduct is water. Water is great. The cell needs water. We know that a majority of the water in our bodies is located within the cell. It also produces CO2. What do we know about CO2? Well, CO2 is bad. It could be a volatile substance to the body, because we know CO2, when you combine it with water, creates acid, carbonic acid. So if you take CO2 plus H2O, it creates H2CO3, which is carbonic acid. So what does that mean? If you allow CO2 to hang around and you're not getting rid of it, or the patient's not getting rid of it because they're in respiratory failure or they're in respiratory rest, and you're not ventilating them adequately, this has nothing to do with oxygenation, but you're not ventilating them adequately, where you're not allowing them to blow off the CO2, that CO2 is going to hang around. It's going to combine with water, and it's going to start forming large amounts of carbonic acid. It's going to start liberating hydrogen ions and so forth. And what you're going to create is an extremely high acidic state. CO2 is good, though, because it's very easy to get rid of. And the way you get rid of it is you allow the patient to blow it off. But the patient has to have available to them, whether you're providing it or it's spontaneous, they have to have adequate ventilation. Okay. And it's primarily the exhalation piece that's allowing the CO2 to be blown off. So CO2 is actually not bad, but if you allow it to hang around, it's going to create acid. And what do we know about acid? Acid is bad. Acid is bad for cells. A little bit of acid's good, but when it begins to accumulate, it's bad. One thing that you'll find acid does is acid has a tendency to shut down the enzymes in the cell. And when you shut down the enzymes in the cell, oh, look, acetyl coenzyme A, it's an enzyme in the cell. That's not going to work appropriately. Enzymes within the cell begin to dysfunction in a high acidic state. So it's bad. One other thing I want to point out here is look at this. If you put a glucose molecule into the cell and you burn that glucose molecule, you oxidize it, 50% of that oxidation of that glucose molecule, 50% of that metabolism of that glucose molecule ends up in the form of heat. You ever want to know, like, where does our heat come from in our body? Our heat is coming from normal metabolism. That is key. That is so important. So we say, well, what's the ultimate goal of emergency care? I told you a little while ago that everything you do in emergency care, whether you're an EMT, an advanced EMT, or a paramedic, everything you do focuses on the same thing. What is that? You say, well, you got to maintain perfusion of cells. And what does that mean? Perfusion. Perfusion means you have to continuously deliver adequate amounts of oxygen and adequate amounts of glucose to the cells. Because if you're able to do that, then what you're going to end up with is a lot of energy, a lot of heat, CO2, which we could get rid of effectively, and water, which we need to reabsorb into the cells, and they have to use that for normal function. Okay? This is all good stuff, all in red. It's all good stuff. Again, don't let the CO2 hang around. It's going to create acid. Okay? Now you say, well, what happens if we don't have adequate tissue perfusion? What's going to happen to the cell? Well, you take the glucose, it looks like a little poop emoji up there. That's a glucose molecule. You put it into the cell, crosses the cell membrane. It goes through glycolysis, remember? It goes through glycolysis because glycolysis is an anaerobic process, okay? And again, we're getting glucose from a lot of different sources too. So, and then what do? We create our pyruvic acid. But here's the problem. Without oxygen, we can't enter the citric acid cycle in the electron transport chain. Instead, what do? We start taking the pyruvic acid and we start creating lactic acid and 2 molecules of ATP. And so then you say, so what happens in a patient with poor perfusion where their cell, their brain cell, their heart cell, their respiratory muscle cell is not getting an adequate amount of oxygen? What do? They start producing mass amounts of acid, and they're producing very little ATP. And what aren't they producing? Heat and CO2. The CO2 is not being produced, but lactic acid is. You can't blow off lactic acid. Lactic acid has to be converted back to lactate in the liver. And once it's converted back to lactate, once you reintroduce oxygen to the cell, that lactate can actually go through the process and produce ATP, CO2, water, and heat. But without oxygen, we continue in this process. 2 molecules of ATP compared to 38. Very, very little energy. Well, I guess I would ask you to say, well, if you had a flashlight with a battery and the battery had very, very, very little charge, what's going to happen to the light being emitted at the end of the flashlight? It's going to be extremely dim. You're not going to be able to see what you need to see. And eventually, that battery is going to be drained and your flashlight's going to fail. And the same thing is going to happen here with this. So now, let's okay, again, here's your comparison. Here's what's happening. Aerobic metabolism. You have a patient. That patient still has good perfusion. Brain's getting enough O2, heart's getting enough O2, lungs are getting enough O2, liver, kidneys, everything. Getting enough O2. They produce a lot of ATP. It's actually 38 when you count the glycolysis part. They're producing CO2, which they're going to blow off with adequate ventilation, water, and they're producing lots of heat. What happens to that patient when they shift to an anaerobic metabolism because their perfusion now has been, I don't want to say eliminated, it could be eliminated, or it has been decreased to a point. Well, we know what's the definition of shock. Everybody here, I bet you, everybody, if I said, what's the definition of shock? Everybody's going to raise their hand and say, inadequate tissue perfusion. And what does that definition mean? Inadequate tissue perfusion does what? Creates anaerobic metabolism. You only make very little energy, lots of acid, no CO2, and no heat. So clinically, what do we know about Jack Nicholson here? Anybody remember the movie? The movie was The Shining. If I saw Jack Nicholson poking his head through the door that he just cut open with an axe, I would think, if you guys remember the movie, Jack Nicholson has a hell of a lot of energy. And in order for him to have a hell of a lot of energy, Jack Nicholson has to have adequate tissue perfusion. That means he has to have an adequate amount of O2 and glucose going to his brain cells and going throughout his body in order for him to have this amount of energy. They say, okay, all right, so clinical application. If your patient is alert, awake, screaming, yelling, pulling at you, wow, they have a lot of energy. And if they have a lot of energy, that tells you something about the tissue perfusion. It has to be adequate. Hey, take a look at this guy. This is actually Larry. The last time we went out for a beer. This is Larry after one beer. I found him in the bathroom. And just look at him and say, what's the clinical application here? Obviously, this guy can barely stand up, doesn't have enough energy to get his face out of the urinal. Well, what's one conclusion we can draw? Well, if he doesn't have an adequate amount of energy, it may be that he doesn't have an adequate amount of perfusion to his cells. He's not getting enough oxygen and glucose to his cells, and he's probably producing a very small amount of ATP. So that's your clinical application, okay? Now let me ask you this. So, you know, how many of, I know a lot of people in EMS got started when they were very, very young, taking like a first aid class, or Girl Scouts took like the, Florence Nightingale, nursing first aid, and, the Boy Scouts took, whatever first aid class. But one thing, even in general, what did I tell you? Oh my gosh, if you have a victim that is bleeding, or you suspect is going into shock, what's one thing they always tell you you have to do? You have to do what? Keep them warm. Put a blanket under them so they're not conducting their heat to the ground. Put a blanket over them. We tell you over and over, preserve their body heat. Make sure you're preserving their body heat. What's a treatment for EMTs, advanced EMTs, and paramedics for a patient in shock? Preserve their body heat. Why is that? Well, we know one thing. If the patient is not in shock, well, we said, okay, what's the definition of shock? Inadequate tissue perfusion, right? Inadequate tissue perfusion means you're not getting an adequate amount of O2 and glucose to the cells. So what does that mean they're in? Anaerobic metabolism. And if they're in anaerobic metabolism, what are they no longer producing? Adequate amounts of heat. So therefore, because they're no longer producing adequate amounts of heat, our patient who's in shock will become hypothermic. Okay, that's why you put a blanket over them and you put a blanket under them. So we have a patient here, stabbed in the right upper quadrant. Patient responds to verbal stimuli only. What does that tell you about his mentation? What does that tell you about his tissue perfusion? You have to start wondering, if he's only responding to verbal stimuli, then, and he's been stabbed in the right upper quadrant, and he's losing blood, this is a great indication that this patient has converted from an aerobic to an anaerobic metabolism, and his brain cells now don't have an adequate amount of O2 and glucose in order to produce the 38 molecules of ATP to allow the brain cells to function normally. That's why he's only responding to verbal stimuli. Why is he responding to verbal stimuli? Because he may have just enough cells with enough O2 that he's able to produce a little bit of function, or maybe the 2 molecules of ATP that he's hanging on to that's giving him just this very slight ability to respond, keeping those cells functioning. But you look at the patient's skin's pale, cool, clammy, heart rate 132, patient's tacking out. Respiratory rate is 28, elevated respiratory rate, BP 78/62. Look at the pulse pressure, very, very narrow pulse pressure. What would you conclude from this scenario? Well, this patient obviously is in hypovolemic shock. You say, well, this patient obviously has converted from aerobic to anaerobic metabolism because he doesn't have enough ATP to keep him awake and aware. But you're outside and you're on the street corner and the ambient temperature outside is 83 degrees Fahrenheit and it's a day where it's 90% humidity. What do we know about those days? You're standing there, you're sweating like crazy. Sweat's rolling down your back, down the crack of your ass, and you're out there and you're like, man, let's get this patient in the back of the ambulance because we got to do what? Man, I got to get cool. It is hot out here. What's a key factor in patient management? It's the last thing you want to do. You have to keep the patient warm. Why do you have to keep the patient warm? Because this patient with an ambient temperature of 83 degrees is radiating his or her heat to the atmosphere. Skin temperature is about 90 degrees. So that means you have a temperature difference, temperature gradient difference. That means his skin temperature is warmer than the ambient temperature. And which way does the thermal gradient go? It goes from the warm to the cool. This patient at 83 degrees with a 90% humidity is becoming hypothermic out on the street. And you're looking at me going, son, you want me to put a blanket over this patient? Absolutely. You know, the other thing I'm going to tell you to do is turn up the heat in the back of the ambulance. You don't put the air conditioner on because all you're going to do is what? Cool the patient quicker. You're going to cool the patient. This patient, because they are in an anaerobic metabolism, no longer has the ability to produce heat. You say, well, what's the big deal about that? Well, we know what? Hypothermia leads to coagulopathies. What does that mean? Coagulopathies, we end up with clotting issues where the patient won't clot normally in the hypothermic state. So now you got a patient who's stabbed probably in the liver, and now you're going to make them cold, and now what you're going to do is cause greater bleeding because it can't clot because you're making your patient hypothermic. On an 83-degree day with 90% humidity, when you're soaking wet, you put them in the back of the ambulance, you cover them up, and you put the heat on. You got to get that heat up to at least 90 degrees so they're no longer radiating their heat from their body to the atmosphere. So, you know, we're going to do a lecture. I'm going to do a lecture on spine motion restriction and so forth and all the issues with backboards. But I just want to bring this up here, too. What's one of the issues with a backboard? So let's take, you know, a day that it's, you know, whatever. Let's say it's a, you know, I don't know, 50-degree day outside. And, you know, I'm sure at this point, most of the ambulances, you store your backboards in the outside compartments. And, you know, so you go to a trauma, you have a patient involved in a trauma, let's say a car crash, and you're going to put your patient on the backboard. Well, if that ambulance was actually sitting in the bay, let's say your bay is 60 degrees. Well, what's going to be the temperature of that backboard? 60 degrees. Well, let's make the day outside warmer. Let's make it a 75-degree day. But the bay is 60 degrees. And you take and you put your patient, they're naked now because they're a trauma patient, and you strip them down, you're supposed to, you expose them, and now you put their naked body on a backboard that's 60 degrees, and they're naked, and it's a 75-degree day outside. For us, we think, well, that's not a bad day. That's actually a pretty decent day. And they're naked. Not only are they radiating heat to the atmosphere, they're doing what? Conducting heat to the cold backboard. Cold backboards cool trauma patients. And that's one of the issues with backboards. It's not the main issue, but that's one of the issues. They found that is that backboards being kept in outside compartments in ambulances on cooler days are cooling patients, and they're ending up becoming hypothermic and then ending up with coagulopathies. And that was one of the issues with backboards. Again, is one of the reasons why they're saying backboards are bad. Again, that's only one. So you say, all right, so, okay, so this is interesting, but so what does it really mean? You say, well, what does it mean to the stroke patient? What's it mean to the heart attack patient? What's it mean to the hypoglycemic patient? What's it mean to the drug overdose patient? Well, it all makes sense when you start looking at this, and you start looking at how poor perfusion will cause cells to die. Well, this is it here. Your cells have a sodium-potassium pump. Now, we know that sodium is the primary intracellular or extracellular ion. Sodium should be outside the cell. It is the primary extracellular ion. Potassium is the primary intracellular ion. Potassium should be inside of the cell, and sodium should be outside of the cell. However, the problem is sodium wants to be inside the cell. Sodium works its way inside the cell, and it wants to stay inside the cell. But realistically, it should be outside of the cell. Well, what did you learn about sodium? Where sodium goes, water follows it. So that means if we put sodium in the cell, water is going to come inside the cell. So our body has a sodium-potassium pump. And what the sodium-potassium pump does is it actively pumps out the sodium and allows the potassium to be, carried in, okay? So the sodium-potassium pump, it's an active process. It requires energy. It actually takes the sodium and it pumps it outside of the cell membrane back into the interstitial space, the extracellular fluid, and it carries the potassium back in where the potassium is supposed to be inside the cell. But again, it's an active process. Anytime we say active, it means it requires energy. It requires ATP. So what happens when our patient goes from aerobic metabolism, producing 34 to 38 molecules of ATP, to anaerobic metabolism, where they're only producing 2 molecules of ATP? 2 molecules is very, very little energy to do what? Run the pump. So now this pump is not able to adequately keep up with the amount of sodium inside the cell. So what happens? The cell begins to do what? Well, the cell begins to do what? As the sodium begins to collect inside the cell, where sodium goes, water follows it, and the sodium continues to collect, and the cell begins to swell and swell and swell, and eventually it swells to a point where the cell membrane ruptures. Once the cell membrane ruptures, the cell's dead. There's nothing you're going to do to now recover the cell. It is dead. Now keep in mind that anaerobic metabolism is producing 2 molecules of ATP. So that means it's going to run that sodium-potassium pump. It's not going to be effective at all. And the sodium is going to continue to collect, but it may keep enough out to sustain that cell for a period of time. So what does that mean? Well, if you can resuscitate this patient and you can restore the oxygen and glucose to the cell, you're going to do what? Turn the pump back on, get rid of the sodium, the water is going to follow the sodium, the cell shrinks back down to its normal size, and the cell recovers, and there's no damage to the cell. If it doesn't, that 2 molecules of ATP can only work for so long before that cell becomes overwhelmed with sodium, and it swells and swells and swells, and eventually it ruptures. And you say, okay, well, that's fine. That's how a cell dies. Cardiac arrest. You say, well, clinically, what does that really mean? So you look at cardiac arrest. You know, the interesting thing about cardiac arrest is, you know, they say like it's critical. The brain begins to die within 4 to 6 minutes. But the interesting thing about it is this: when a patient goes into cardiac arrest, the oxygen is gone out of their brain in about 10 seconds. The glucose is gone out of their brain in 1 minute. So what does that mean? After 10 seconds, those brain cells start converting from an aerobic to an anaerobic metabolism. After 10 seconds, sodium starts beginning to collect in the cells, the brain cells, because the brain cells can't pump out the sodium adequately with only 2 molecules of ATP. And then in 1 minute, they lose the glucose, because we know one thing: your brain cells pretty much only run on glucose. They can't collect glucose. They can't make glucose. They can't store glucose. They can't concentrate it from the blood. So in about 1 minute, they run out of glucose. So not only do you not only have not enough oxygen that puts them in an anaerobic state, but now when you lose the glucose, you have no metabolic state, and the sodium-potassium pump fails completely. And when it fails completely, sodium stays inside the cell, continues to invade the cell, invade the cell, invade the cell, and all of a sudden invades it to a point where that cell membrane can't take on more fluid, and it eventually ruptures because the water's following the sodium. So they say, well, in 4 to 6 minutes is when brain cells begin to die, but your brain cells start suffering from what's called a cytotoxic edema after 1 minute after cardiac arrest. And that edema is related to the shutdown of the sodium-potassium pump. But here's the thing: if you can get O2 and perfusion restored, perfusion with O2 and glucose restored to the brain, what are we going to do? As long as that cell membrane is not ruptured yet, it's swollen, but as long as it's not ruptured, what do? We turn back on the sodium-potassium pump, and all of a sudden we can get rid of the sodium outside the cell, and suddenly now that cell begins to shrink back down again. Okay, that's how your person dies at cardiac arrest. I just used the example of the brain, but trust me, the liver cell, all these cells are going through the same thing. How about a sustained shock state? A patient who's in hypovolemic shock, septic shock, whatever it would be, that inadequate tissue perfusion, the same thing occurs as in cardiac arrest. They shift from aerobic to anaerobic metabolism. Sodium-potassium pump is working ineffectively with 2 molecules of ATP. Eventually, those 2 molecules can't keep up with the sodium inside the cell. It swells, and then eventually it ruptures, killing the cell because the water is following the sodium inside the cell. So you have to ask yourself this: what's one of the major hallmark signs of hypoglycemia? What is one of the major hallmark signs of hypoglycemia? Altered mental status, correct? Could be anything from confusion, irritability, to complete coma state. Why is that? Well, think about it. And why is the brain affected so rapidly? Well, if you think about it, you say, well, the brain cells could pretty much use only glucose as an energy substance. There's some other substrates, but very minute. So what happens in hypoglycemia? You are not putting an adequate amount of glucose into the cell. And if we don't put an adequate amount of glucose into the cell, that means that it can't go through a normal metabolic process of oxidizing that glucose. And if we don't have glucose available, that means that we can't make ATP. And if we can't make ATP, that ATP is energy to the cell. And if we don't have ATP, there is no energy to allow the cell, the fuel, to function. And so what happens? When there's not enough ATP and the cell's not able to function because it doesn't have the energy, what do we see clinically? Confusion, irritability, disorientation, responding only to verbal commands, responding only to painful stimuli, or complete coma. And that's all related to this aerobic state from the lack of glucose. And again, why does the hypoglycemic patient go from an awake aware state to a maybe an awake and unaware state, or to an unawake unaware state so quickly within minutes? Because you don't put glucose in a cell, you don't produce ATP. If you don't produce ATP, you don't have energy to run the cell. And if you're not running the cell, that patient can't tell you their name, they can't tell you their address, they can't open their eyes, they can't maintain any of its normal function. Okay? Hopefully it makes sense. Cocaine overdose, you say, well, what the heck? Cocaine overdose? What do we know about cocaine? Cocaine is a very vasoactive substance, right? Okay, so what does cocaine do? Cocaine is so vasoactive in certain situations, it will cut off peripheral circulation because it's so strong through vasoconstriction. And if we cut off peripheral circulation, what happens? Inadequate tissue delivery, perfusion, inadequate tissue perfusion of oxygen and glucose. What happens in cocaine overdose? That tissue starts converting from aerobic to an anaerobic metabolism. You lose your ATP, cells begin to die. Okay? So those are some clinical examples of how this is actually related to, clinical medicine. So I'll give you this scenario. So if you arrive on the scene of an auto crash, we have a car that crashed into a, concrete structure, let's say a bridge pillar, going 60 miles an hour, and you have two patients in the front of the vehicle. And you and your partner arrive on the scene, and the driver of the vehicle has this open humerus fracture, bone sticking straight out. There's some bleeding, and the patient is yelling and screaming for you to come help them. They're yelling, oh my God, look at my arm. Oh my God, it hurts. Oh my God, this is terrible. Look at my arm. Look at my arm. They're grabbing at you. They're fidgeting in the car. They're yelling at you to do something for them. And then you have the passenger of the vehicle, and your partner goes over and says, hey, buddy, how you doing? And the guy goes, I'm okay. Who do you go to first? Who's your more severe patient? Well, we know one thing about the driver of the vehicle: yelling, screaming, flailing, moving, grabbing. It takes a lot of energy to do that. And if that patient has a lot of energy, it means that they're getting an adequate amount of O2 and glucose to their cells. So that means that they couldn't be in a shock state at this point. Okay. And that humerus fracture, we know what? That's not going to kill them. Humerus fracture is not going to kill this patient. It's dramatic. You want to take care of it right away, because people at the scene are saying, oh my God, what are you doing? You're going to leave that guy. Look at that bone sticking out. And that guy said he's okay. What are you doing over there with him? Well, the patient who's sitting there, who just lifts his head up, who could barely keep his eyes open, doesn't have energy. And what is that telling you clinically? He doesn't have energy. So there's a good chance that this patient doesn't have adequate tissue perfusion. Me personally, I'm going to take care of that patient first. Guy screaming with his humerus, tell him hold his arm still, you'll get to him. Okay? All right. Hopefully that makes sense. We are going to take, it is 7:01. I'll tell you what, this will probably be a good place. Matt, are you okay if we take a quick break here?
Absolutely. That's not a problem. What do we think? 5-10 minutes?
Yeah, let's say let's be back on. I will restart at 7:10.
Sounds good.
Okay. Thank you. 7:10.
This would be a good time for everybody, if you can, to sign in on the chat box and or raise your hand so that we know you're still here and with us.
Oops. All right, 7:10. Are we ready to go, Matt?
We sure are, Joe. Hey, would all participants now please lower your hand? Please cancel your raised hand. Thank you.
Okay. So let's talk a little bit about oxygen and oxygenation now. Okay. So we know that oxygen is a key component to metabolism, aerobic metabolism. But I want to talk about how oxygen also could be bad. So I know, I'm sure everybody's heard of free radicals. And if you say, well, why do we age? Well, the primary reason why we age is because of this production of free radicals inside of our body, inside of our cells. And these free radicals are what actually damage, and they actually will, damage the cells and manipulate the DNA and so forth. And so basically what I want you to know is that if you say free radical, anytime you say a free radical, now again, if you look at all of these are all pretty much, a lot of environmental concerns, some of these, from within the body, metabolism, inflammation. We're going to focus on the metabolism piece. But if you look at the free radicals themselves, anytime you say, well, free radicals are bad because free radicals damage cells and they lead to cell death if they're unchecked. And one thing that I do want you to take a look at here is when you look at this free radical is primarily a hydroxyl radical, and a hydroxyl radical is nothing more than an oxygen molecule and a hydrogen molecule. So you need an oxygen molecule and a hydrogen molecule to produce free radicals. And the more free radicals you produce, the worse cellular damage you're going to end up with, and the greater the cell death. So just keep that in mind as we move on. So you say, okay, so all right, so here we have all these different conditions affecting the cell, right? Ischemia, inflammation, reperfusion injury, toxic agents, oxygen toxicity, radiation, and so forth. And you say, okay, so what's happening with that? Well, O2 is a key component in here. And you look at the one thing that I had highlighted is the hydroxyl radical, which again is made up of an oxygen molecule and a hydrogen molecule. And this is a key component because this hydroxyl molecule is one of the key components in producing a free radical. And we already said free radicals are bad for cells. If you're producing free radicals, you don't want to be, because free radicals are what's going to cause cell damage and potentially cell death. Okay. So what happens with free radicals? Well, when free radicals are liberated in the cells, when they're produced in the cells, they break the lysosomal membrane. And when you release the lysosomal membrane, or you break the lysosomal membrane, histamine leaks out, and this will begin to start eating away at the cell membrane. The lysosomes will begin to eat away at the cell membrane, eat away, and break down the nuclear membrane and so forth. They'll alter the genetic material. But basically here, if you notice this, free radicals attacking the cell membrane from the inside. So these free radicals are actually being produced inside the cell, and they're actually attacking the cell from the inside out. And the main thing the free radical is going to do is, again, break down the lysosomal membrane, release lysosomes that will begin eating away at the cell membrane. And remember earlier I said, once your cell membrane is destroyed, that cell dies. I don't care what you do, the cell's not going to regenerate. That cell is going to be dead. So if these free radicals are plenty enough, and there's enough of them and active enough, they begin to destroy cells by breaking down the cell membranes from the inside out, okay? And you say, okay, so, well, where do free radicals come from? And you say, well, free radicals are being produced in anaerobic metabolism, okay? Let me say that again. Free radicals are being produced in anaerobic metabolism. That means when you have a poor perfusion state, when you have an inadequate perfusion state, shock, stroke, MI, and you block perfusion to tissue, okay, and those cells go from aerobic to anaerobic metabolism. During that anaerobic metabolic state, where you have the low O2 state, you are now producing free radicals, okay? But you say, well, okay, what is the low perfusion state? And notice oxygen, remember, is necessary to produce a hydroxyl radical because it's an oxygen molecule and a hydrogen molecule that combines to produce the hydroxyl molecule, which is the key in the free radical. So if I don't have a lot of oxygen available in anaerobic metabolism, how many free radicals can be actually made? Because you're in an anaerobic metabolic state. It's a good question. It's a good point. But what does that mean? If you take an MI patient, or you take a stroke patient, or you take a shock patient, and you restore perfusion either through, whether it be balloon angioplasty, through TPA, TPA for the stroke patient, or some endovascular procedure, whatever it would be, and in the shock patient you restore their blood pressure and you restore their perfusion to the cells, we then shift from anaerobic metabolism back to aerobic metabolism. We now have oxygen and glucose getting back to the cells. We have oxygen available, so we're shifting from anaerobic to aerobic. Great, that's awesome. But what do we have lingering? Free radicals that were produced in the anaerobic metabolic state. And we are still hyped up to produce free radicals. So what does that mean? If I blow this patient full of oxygen, and they got a ton of oxygen available because I got them on a non-rebreather mask at 15 liters per minute, that means when they restore perfusion to that area of the heart, and that heart starts shifting from anaerobic to aerobic, and it's being bombarded with oxygen because this patient's on a non-rebreather at 15 liters per minute, and their PaO2 is 200, what happens? There's a ton of oxygen available. The cells are primed to produce free radicals. Now we have a ton of oxygen to combine with hydrogen. And what happens now when you shift to aerobic metabolism and you restore the perfusion? You start producing a mass amount of free radicals. What do free radicals do? Damage the cells, destroy the cells. So by actually flooding your patient with oxygen, and the MI patient, in the stroke patient, in the cardiac arrest patient, in the shock patient more than what they are required to have, what you're doing is making a ton of oxygen available to a cell that's primed to produce free radicals, and now you let them go, and it's kind of like they're unchecked. Now they got a ton of oxygen, they're going to make a ton of free radicals, and when the perfusion is restored, and you're thinking, oh, this is great, we've restored the perfusion, awesome, we're going to shift back to aerobic metabolism. Believe it or not, the cell damage continues, or it actually increases when you shift back to aerobic metabolism when there's a ton of oxygen available. Who made the oxygen available? You did, by putting them on a non-rebreather at 15 liters per minute. So any reperfusion type injury, if your patient is not hypoxic, you don't put them on O2. And the reason why you're not putting them on O2 is because what you want to do is make as little oxygen available when reperfusion is restored, or perfusion is restored, and the cells are reperfused, to limit the production of free radicals when you release the O2 back to the cell. That's why you're going to limit oxygen therapy. That's why oxygen is bad. In the old days, it was put as much oxygen. The more oxygen you put on the patient, the better it is for the patient. Not true anymore. In general, oxygen should no longer be administered just as a free-for-all drug. Put them on non-rebreather 15 liters per minute. If there is no indication for high flow, high concentration oxygen, then there is no reason to give high concentration oxygen. Okay. Let me tell you one patient, though, that needs high concentration oxygen. One patient that needs a non-rebreather at 15 liters per minute, regardless of the SpO2 reading. And that is a pregnant patient who is greater than 20 weeks gestation. A pregnant patient greater than 20 weeks gestation who has suffered some type of medical issue, some medical, incident or trauma, regardless of what that patient's SpO2 reading is. If that patient's SpO2 reading is 98% on room air, and she is greater than 20 weeks gestation, she gets a non-rebreather at 15 liters per minute. And the reason for that is because you have no idea what the utero-placental oxygen perfusion is like, the oxygen concentration to the fetus, so therefore you maximize oxygenation to the fetus. At this point, it's not oxygenating the mother, it's actually oxygenating the fetus. That's one situation where you forego the SpO2 reading and you go ahead and give a non-rebreather 15 liters per minute, especially, again, in a patient suffering a significant medical insult or a traumatic injury where there is question of perfusion and so forth. Okay, so that's why oxygen is bad, because of the production of free radicals. Okay, here again, this is what we talked about. The consequences is just make a whole lot of oxygen available to make a whole lot of hydroxyl radicals to make a whole lot of free radicals. So we know oxygen hazards in an MI. So a patient is having an MI, and you're like, okay, so what are the hazards of oxygen? Administering too much oxygen to the patient who's having an MI. And we know one thing: if you have a patient having chest pain, who or you suspect is having an MI, you have a STEMI on your monitor or whatever would be in your 12 lead, and the patient has an SpO2 of 96%, they don't need O2. They don't need O2, because by putting them on O2, if they're able to reperfuse this ischemic tissue, okay, that's not dead yet, it's ischemic tissue, and you're giving them O2, and you increase their PaO2 beyond normal, you're going to actually create more hydroxyl radicals. You're going to create more tissue damage that will continue after they reperfuse that tissue because of the oxygen that you had administered. Here's another problem with oxygen. Oxygen is a vasoconstrictor. Oxygen will cause coronary arteries to vasoconstrict. So that means the more oxygen you have available, the more oxygen you have on board, the more coronary artery constriction you will have. And that's not what we want. We want actually those coronary arteries to dilate, to deliver as much oxygenated in blood with glucose, and I'm not contradicting myself here, as much blood with oxygen. Let's not say as much oxygenated blood, but as much blood with oxygen to restore our aerobic metabolism. But by constricting coronary arteries, we're going to reduce that distal perfusion and reduce it to the area of ischemia, and we could actually worsen the ischemia. So these are two major problems in your patient having a heart attack. Free radical production that you could worsen with O2 therapy, coronary artery vasoconstriction that you could also worsen with oxygen therapy. How about the stroke patient? Well, the ischemic stroke, this is not hemorrhagic. Hemorrhagic stroke's totally different. This is an ischemic stroke patient. The ischemic stroke patient, it's no different in the ischemic stroke than it is in the heart attack. It's the same physiology. It's the same thing. We have ischemic brain tissue. If they can go in, if they could TPA the patient or do some type of endovascular procedure, remove the clot, restore the perfusion, if they have a ton of O2 available, once they restore the perfusion to that brain cell, and you got all this O2 available, you're going to produce a ton of free radicals, and you're actually going to cause further brain cell damage. It sounds crazy. You know, if I would have said this, 25 years ago, 30 years ago, people would have thought I was nuts. Like, we were always teaching, we were always taught, we were always, oh my God, a stroke patient, they need O2 for their brain. We got to get them as much O2 as we can. But as medicine evolved in EMS, I'm proud of EMS because they do things based on evidence-based medicine. They're like, no. This is actually harming patients. If you have a patient with an ischemic stroke, okay, thrombotic embolic stroke, and they have a normal SpO2, an SpO2 of 94% or above, they get no O2, okay? Because the O2, again, will increase the free radical production upon reperfusion. And again, this is coronary artery vasoconstriction. Should be cerebral artery vasoconstriction, not coronary. Sorry. Should be cerebral artery. Yes.
Hey, pre-hospitally, there's a lot of research out there saying that even, locally, what we're doing is 90%.
Yes.
So 90% for coronary artery STEMIs, non-STEMIs, and also strokes. We're keeping it at that 90% threshold. So you'll see a lot of these patients not even getting any oxygen therapy, but also COVID patients too. COVID-19 is projected to be a vasculitis because it affects all parts of the body. So there's a lot of research coming out to say, even though your patient may not be ventilating or perfusing as much as they want, that free radical oxygenation may actually be worse if we adjust the SpO2 above 90%. So I just want to throw that out there for our local providers here, that 90% is what we're doing here locally for our cath labs, both at St. E's and Trumbull and Sharon. That's what we're trying to keep it at 90.
Yep. That's a great point, Larry. Thank you. Because it's interesting, because if you go in the hospital, if you ask respiratory therapy, what SpO2 would they consider to be hypoxic? It's less than 90%. And the only reason why EMS went with 94%, because I often wondered that myself. And the only reason they went with 94% is because we don't have the diagnostic tools available to us. And so the theory behind it is it's a little bit better to over triage and give O2 than to withhold O2 if you're not sure. And I know that's a little bit contradictory, but as Larry's saying and again, I would not be shocked if in the future that this actually goes, like there's a set of national guidelines that were drafted by NASEMSO, which is the National Association of State EMS Officials. All the state medical directors drafted a set of guidelines, and they're still 94%. But I wouldn't be shocked. And it's interesting, Larry, so that you guys, again, have a progressive protocol. So that's why you're seeing it. So again, if you're at 90% or, higher, then absolutely, I would agree 100%, because again, if you go in the hospital, they're using an SpO2 at 90% as an indication of hypoxia. So that fits right in. Yep. Thanks, Larry. Here, so Larry took my thunder out of the COVID infection. Thanks, Larry. He probably thought I wasn't going to, cover it. So But anyways, here's another thing that's interesting because, and I'm actually shocked still because the surgeons are involved, and the American College of Surgeons, I mean, unless they have the most concrete evidence, they don't want to change anything. But they recognize the shocked patient, a patient who's in hypovolemic shock, it is nothing more than a global hypoperfusion injury. And when you restore perfusion, it is a global reperfusion incident that you could end up with reperfusion injury. However, the surgeons are still big on give them the O2. I thought by now the surgeons would have came out and said, in a patient in a hypovolemic shock state, limit your O2, at least get away from the non-rebreather, get away from the high concentration O2, go with the low O2. But they didn't. So we'll see what happens. But keeping in mind, if you're sitting there wondering, well, isn't shock inadequate tissue perfusion? Doesn't it produce anaerobic metabolism? Doesn't it produce hydroxyl radical production? Doesn't reperfusion, once you resuscitate them and they have a non-rebreather, cause an increase in cell tissue death from free radical production? It sure does. But right now, they haven't changed their position on it. Larry mentioned the COVID infection. As Larry said, this is a vascular issue as much as it is an oxygenation issue. I actually think it's more of a vascular issue, and it's more of a coagulation issue and a blood component issue. But one other thing, too, that I want to mention, and I'll talk a little bit more about this, too, is in the COVID infection, is so what they're saying is, early on, they're saying, oh, well, COVID infection, we can't oxygenate. Remember, they were saying this isn't a ventilation issue, but yet they're putting people, intubating and putting them on ventilators. It made no sense whatsoever. All right, it's an oxygenation issue, and these patients were presenting like an acute respiratory distress syndrome, where they had then the increase in capillary permeability in the pulmonary capillaries. They had the increase in the alveolar capillary interface. They had leakage of fluid around the alveoli, leakage of fluid into the alveoli. They had atelectasis from the fluid collapsing the alveoli. Same as the ARDS patients. So what are they doing? Pounding them with O2, mass amounts of O2. Well, one thing you got to be careful too is in a patient where you're giving them large, high concentrations of O2 for a period of time is, nitrogen makes up about 79% of the atmospheric air. And if we wipe out the nitrogen by pushing the nitrogen out of the alveoli and allowing only oxygen, what happens is the nitrogen is no longer there to actually keep the alveoli inflated. And so what happens is with the nitrogen washout, the alveoli collapse. Now all of a sudden, now you have fluid around the alveoli, putting tension on the alveoli. Now you're washing out the nitrogen. Now you have atelectasis where the lung tissue is collapsing. And now you have a patient that they go from, respiratory distress to respiratory failure to respiratory arrest because they are worn out from trying, the COVID patients, I'm worn out from breathing. And this is why, because every time they go to take a breath, it's like their first breath as a newborn, where they have to re-expand and open all the alveoli. Well, this is what's happening. And again, the free radical production from mass amounts of oxygen too. So again, COVID infection, they're saying, be careful. Be careful with high flow. I'm sorry, I keep saying high flow, high concentration oxygen. So these are some other complications with oxygen therapy. And we used to think, O2, O2 is an innocuous drug. Give a person as much O2 as you want. It's good for them. Well, we know about the COPD patient and knocking out the hypoxic drive. I'm not going to cover that right now. I may do a little bit later. We'll see time-wise. But that is true. There's a lot of COPD patients who do not have a hypoxic drive. Again, we breathe to get rid of CO2. We're breathing right now because of our CO2 concentration in our arterial blood. We're not breathing to bring in O2. We're breathing to get rid of CO2. And what happens is because of retaining CO2, these COPD patients, because their CO2 level is always high, they become desensitized to that CO2 level. I used to explain, say, well, anybody here have like an injury, like an ankle injury or something, you have pain constantly? Well, eventually you kind of do what? Forget about that pain. You kind of become desensitized to it. Well, it's the same thing with CO2 and the COPD or retained CO2. Their chemoreceptors become somewhat desensitized to the high CO2 level, so they quit breathing to get rid of CO2 and they switch to breathing to bring in O2. So they're breathing on their oxygen level instead of their CO2 level. And so what happens then is in these patients with the hypoxic drive, if you come in, put them on a non-rebreather, 15 liters per minute, and you maximally increase their O2 in their blood, all of a sudden their chemoreceptors are saying, whoa, 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 we got way too much O2. We don't need all this O2. So let's stop breathing for a while. And that's what happens. That's how you knock out the hypoxic drive. With the CO2, it's never going to happen, because even if you put them on a mass amount of oxygen, as long as they're creating CO2, you're going to be breathing based on the CO2 level. Now, the whole thing is if you have a COPD patient, the only thing is maintaining their SpO2 between 88 and 92%. Okay. That's all, So and again, as Larry was saying, 90% is acceptable. And these patients, I've actually seen it as low as 86 too, where you're okay to keep them a little bit lower, okay, on the scale. And again, a COPD patient, if they need O2, give them O2. Don't deprive them of the O2. If they're obviously hypoxic, give them the O2. You're never going to withhold O2 from anybody who has obvious hypoxemia. Absorption atelectasis, and this is what we're talking about basically, is displacing the nitrogen. It's called absorption atelectasis, and this is where you take and you wash out the nitrogen, and the alveoli are no longer staying distended because the nitrogen's gone. It's replaced with oxygen. So the alveoli collapse after every time the patient exhales, and on the next breath, this patient now has to do what? Re-expand the alveoli, and it takes a hell of a lot more energy on inhalation using respiratory muscles to do so. So what are they going to do? Wash out the nitrogen. They're going to go to respiratory failure real quick, and you're going to be bagging these patients. Okay, that's a problem with too much O2. Okay, again, 80% of the gas in the alveoli is nitrogen. Okay, it's not oxygen. I like for the firefighters when people say like, oh yeah, they got those tanks on their back. That's 100% oxygen. I don't know about you guys. I wouldn't be going into a fire with 100% O2 on my back. That's for sure. Plus, you wouldn't last for more than about 5 minutes because you'd be laid out on the ground unresponsive from 100% breathing 100% oxygen. Oxygen toxicity is another problem. So what happens is, we already talked about this. Basically, oxygen toxicity is production of free radicals, because you have so much O2 available, so much O2 hanging around, that you start getting alveolar damage because free radical production, because of the O2 that's available to connect with the hydrogen molecules. So oxygen toxicity is an issue of free radical production that's actually going to destroy lung tissue, destroy alveoli, destroy lung tissue. Okay, absorption atelectasis, you're washing out the nitrogen, causing the alveoli to collapse. Oxygen-induced hypoventilation, hypoxic drive is the COPD patient, where you're given the O2. We already said this. We know that it causes local vasoconstriction, coronary artery, cerebral artery vasoconstriction. Here's an interesting thing. So, you have a patient with hyperventilation syndrome, right? True hyperventilation syndrome. They're not hyperventilating because of a underlying medical cause or, underlying pathology. You have a patient who got a brand new car and she's pulling out of the driveway. Notice I say she, I'm sorry, women out there. Let's say he, let's not imply that women are bad drivers. My mother-in-law is a terrible driver. So let's say my mother-in-law got a brand new car and she's pulling out of the driveway, and her brand new car, and she hits my neighbor's mailbox. Boom. And she crushes the rear quarter panel. Brand new car, just brought it home a day ago. Okay. She's so upset emotionally. She's not injured. She hit a mailbox going about 3 miles an hour, but she smashed the rear quarter panel. She's so upset emotionally, she begins to hyperventilate. So she's in a hyperventilation syndrome, right? I'm sure all of you out there who work the EMS have seen patients in a hyperventilation syndrome. What are their complaints? What's usually their number one complaint? I can't breathe. I can't breathe. I can't breathe. Well, what do we know about hyperventilation syndrome? They're breathing way too deep and usually way too fast. So that means they're bringing in way too much oxygen and they're eliminating way too much CO2. They're breathing way too much, not enough. But yet their complaint is, I can't breathe. I can't breathe. I can't breathe. What's another complaint of theirs? Lightheaded, dizzy. They get the carpal pedal spasms where their hands begin to cramp, their toes begin to cramp, right? But they start getting lightheaded and dizzy. And some of these patients actually have a syncopal episode. They pass out. So I say, well, how in the hell is a patient passing out when they're breathing way too much? Well, if you think about it, when you think about O2, when you think about the response to O2 in the cerebral artery, and there's a CO2 component to this too that's very strong, you're taking a cerebral artery, cerebral arteries, you're putting mass amounts of oxygen in them, and because this patient is breathing so deep and so fast, they're washing out tons of CO2, tons of CO2. Well, if oxygen is a cerebral artery vasoconstrictor, that means that CO2 would be a cerebral artery vasodilator. It's going to keep the vessel open. So what happens in hyperventilation syndrome? They're breathing in so much O2 and eliminating so much CO2 that the cerebral artery has way too much O2, causing it to constrict, and it doesn't have any or enough CO2 to allow it to dilate, constricts. And hyperventilation syndrome, what does the patient do? They basically shut off perfusion to their own brain. You're hyperventilating. You're bringing in a mass amount of O2 and eliminating a mass amount of CO2. They shut off perfusion to their own brain. So what happens? They pass out. And when they pass out, they almost immediately start to wake up. Because what did they quit doing? Hyperventilating. And as soon as they start to breathe normally, the CO2 begins to, again, replenish itself, starts to dilate the cerebral arteries. The O2 is going down, the CO2 level is going up. All of a sudden, it opens up that cerebral artery, restores the perfusion, restores the oxygen back to the cells, restores the glucose back to the cells. And as soon as we do that, we start making what? ATP. And as soon as we start making the ATP, what happens? Cell turns back on again. And when the cell turns back on, what happens? Patient starts waking up. They then tell you their name. They then tell you where they're at and so forth. So that's the hyperventilation syndrome is a great example of how way too much O2, way too much ventilation can actually decrease cerebral perfusion pressure. This is very, very interesting. We talk about, head injured patients and the impact of overventilation in a head injured patient. It is profound. It will definitely increase damage, brain cell death and damage and so forth. So another hazard is retinopathy of prematurity, ROP, and that is O2 actually will cause scar tissue formation in the eye of a premature baby by too much O2. And right now with neonates that need ventilated, they're ventilating them on room air. They're not even starting with ventilation with O2. They're being ventilated on room air. And then obviously, again, the production of the free radicals. We already know that. We already said this. We talked about this, and we know this too, right? You're going to follow this is an old guideline, but I just threw it in there because it's an old guideline. This was 2010. We're 2021. We're 11 years away. So hopefully everybody is guiding their SpO2, guiding their oxygen administration by SpO2. And if your patient has an SpO2 of less than 94%, then you should consider O2 administration. Again, as Larry is saying, and Matt, if you have that MI patient, if you have that stroke patient, and so forth, they're using an SpO2 of 90. They're above the game here, and definitely that 90% is a good guide because you're even being more cautious to not produce free radicals. Okay. So oxygen therapy, if you have a patient with an SpO2 less than 94%, if that's what your orders say, or less than 90% in the case of the MI and so forth, You start with a nasal cannula. You do not start with a non-rebreather. You start with a nasal cannula at 2 liters per minute. And then what you do is you continue to titrate to achieve the SpO2 that you're trying to achieve. Again, in the case of Trumbull Memorial Hospital, if you're trying to achieve an SpO2 of 90%, you put them on 2 liters per minute via nasal cannula. Okay, you give it a few minutes, you see where you're at. If it's not increasing, you increase it by 1 liter per minute. Not working, you go up 1 liter per minute until you can achieve that SpO2 of 90% or 94%, depending on what your orders say. You don't start with the maximum, you start with the lowest concentration. This is for all patients, though. This is for all patients. This is not just for your MI patient. This is not just for your stroke patient. This is for any patient who has an SpO2 lower than what your orders say it should be. You're going to start with a nasal cannula, except for the pregnant patient, 20 weeks gestation or greater, and also the trauma patient. So O2 therapy, if you have a severe case of severe hypoxia, something like, we're going to talk about different causes of hypoxia, but if you have like a patient with a histotoxic hypoxia, which would be something like a cyanide poisoning, you would likely immediately go to a non-rebreather. You might want to consider CPAP on some of these situations. One thing they found with the non-rebreather too is they found the non-rebreathers are very claustrophobic, and most patients, you increase their respiratory effort by putting a non-rebreather on them because they feel it's enclosed, they feel like they can't breathe, and so what you actually do is make them work harder to breathe by putting a non-rebreather on them. Okay, so just be careful with the non-rebreather. Some patients actually you're going to do a lot better with a nasal cannula than with a non-rebreather because they just don't like having that non-rebreather on their face. Fraction of inspired oxygen, all it is, instead of expressing the oxygen that the patient is breathing in as a percentage, is actually expressed as a decimal or as a whole number. So if you're giving your patient 21% O2, obviously you're not giving it to them, they're breathing room air, their FiO2 would be 0.21. If you have them on, whatever, a non-rebreather, and it says, maybe in your orders or something, you have a transport order, it says maintain an FiO2 of close to 0.95% as possible, not 0.95, maintain an FiO2 of 0.95 as close as possible, then that patient more than likely would get a non-rebreather, because we're talking about a fraction of inspired oxygen. We're not talking about SpO2, you're talking about what concentration of oxygen are they breathing in. 100% oxygen breathing in is an FiO2 of 1. So that's all this means. So if you see an FiO2, all it means a fraction of inspired oxygen, and it's expressed in a decimal. It's not expressed in a percent. It's simple. Just take, instead of 95%, 0.95, where the only whole number is 100% O2 is 1. Okay. So I just throw that in there. That's part of the NCCP too. I want you to know that, because sometimes during transports and so forth, they'll say, set the FiO2 at 33% or something like that. Very hard for EMS to do unless you're, using, Venturis or something like that. FDO2, you'll see sometimes, FDO2 instead of fraction of inspired. If your patient is in respiratory arrest, you're delivering the O2. So an FD is nothing more than you delivering it. And that delivery would be typically by bag valve mask or by a ventilator or something of that nature. It's no different. If they say, bag the patient with an FDO2 of 0.21, that means you're going to use room air. If they say bag your patient with an FDO2 of 0.95, that means you're going to hook up your oxygen to a reservoir and you're going to get as close to 100% as possible. That's, we're limited on oxygen concentrations and the precision because we don't have any way to be real precise. Now, here's one way, high flow versus high concentration. They're two different things. High flow does not mean high concentration. High concentration means that the, concentration of oxygen molecules you're delivering is very high. High flow just means that it's a high flow of oxygen. So if you're using a Venturi mask, like here, they have the different entrainment valves. Some of these are using high flow, but they're only delivering a very set concentration of oxygen that might be 45%, And so high flow does not mean high concentration. So they're two totally different things, We also have the high flow nasal cannulas now. that you could deliver greater flow of oxygen through the nasal cannula with the reservoir. So you may be seeing some of those in home healthcare and so forth. So what's a problem here? What's a major problem here with this non-rebreather administration? One of the mistakes that people make is they don't fill the reservoir bag before applying it to the patient. Remember, the patient's tidal volume, this is a non-rebreather. That means they're not rebreathing any of the O2 that has been, any of the air that has been exhaled. None of the tidal volume. All of their tidal volume, for the most part, except what's being drawn in where the mask is sealed, is coming from that bag. If that bag is not inflated with O2, then every time they go to take a breath, they can't take an adequate breath because they don't have enough tidal volume because the bag's collapsed. Please, 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 if you're putting a non-rebreather on your patient, close the port, make sure you fill the bag with O2 before applying it to the patient. Otherwise, you're going to be basically suffocating them, and they're going to have to catch up with the volume in that bag once it starts to fill. So you're using a non-rebreather because your patient's severely hypoxic. Now you're going to make them worse because you're putting a non-rebreather on them where you're not giving them enough tidal volume because the bag's collapsed. Okay. This is obviously an EMS training class, and the uniqueness. I don't know if this is an aerosol treatment with iced tea or something. Don't know. And I just love this picture because I just want this to be me on the beach, with a non-rebreather, I guess. But I don't know if that'd probably be nitrous oxide, not oxygen. So, clinical application, arrival on the scene. You have a 23-year-old male patient who was stabbed in the right upper quadrant. Okay, presents with a decreased mental status, heart rate 138, BP 74/58, pale, cool, clammy skin, respiratory rate 32 at adequate tidal volume. With some perfusion status, obviously, pale, cool, clammy skin, tachycardic, hypotensive, narrow pulse pressure. Well, we know one thing his perfusion status is he has inadequate tissue perfusion. Are his cells hypoxic? Absolutely. Well, let me ask you this. If his cells are hypoxic, by putting the patient on a non-rebreather 15 liters per minute, are you going to reverse the cell hypoxia? Here we have a patient who's obviously in a poor perfusion state. His cells are hypoxic. His cells are converting from aerobic to anaerobic metabolism at an alarming rate. And you go, I'm going to fix this by putting him on a non-rebreather 15 liters per minute. Will it reverse the cell hypoxia? Well, let's look at cell hypoxia. There are different types of cell hypoxia. There's hypoxemic hypoxia. Hypoxemic hypoxia is where you can't get enough O2 into the alveoli, or you can't get the O2 across the alveoli, across the alveolar capillary interface and into the capillary. So you have a disturbance that's either in the alveoli or it's between the alveoli and the capillary, and you can't get the O2 across. That's hypoxemic hypoxia. When you say hypoxemic, what you're referring to is the oxygen level in the blood. Hypo means low, oxygen, emic in the blood. Okay? So hypoxemic hypoxia means there's not enough O2 getting across the alveoli and getting into the blood. Okay? You say, well, what conditions would lead to cellular hypoxia due to hypoxemic hypoxia? And what's the treatment? Well, okay, so what conditions? Well, how about asthma? Here's your normal bronchiole. You notice here that it's nice and open, no mucus production and so forth. And now the patient has an asthma attack. You notice there is bronchoconstriction. Look at these muscle bands compared to here. You notice the inflammation, okay? There's mucus production and so forth. So you have an extremely high airway resistance. Well, this is a prime example of a hypoxemic hypoxia because why? Here's the conduit, and this conduit can't deliver an adequate amount of air to the alveoli with an adequate amount of oxygen. You're just not getting enough O2 into the alveoli. You're not getting enough air into the alveoli, okay? So let me ask you, by putting this patient on a non-rebreather mask at 15 liters per minute, are you going to really reverse the hypoxemic hypoxia? Are you going to really get more O2 into the capillary and attach to the hemoglobin? That's real questionable. Might get a little bit more, but why aren't you getting it there? Because you can't get the air through the bronchiole. So what do you need to do? Is you need to get this bronchiole to open up. How are you going to do it? We're going to bronchodilate, right? And you're going to give steroids and reduce the inflammation, all right? And the steroids right now are probably more important than the bronchodilators. So you're going to reduce the inflammation, bronchodilate, open the bronchiole. So now that conduit is open, and now you don't need a non-rebreather mask. So you're not going to reverse hypoxemic hypoxia in the asthma patient by just putting them on a non-rebreather. It's not going to do a whole hell of a lot of good because you're not getting any air. Not, I would say any. You're getting a very minimal amount of air into the alveoli. Okay. How about pneumonia? If you have a patient with pneumonia and they have fluid-filled alveolar sacs, they have purulent fluid around the alveoli, they got purulent fluid in the bronchiole, putting them on a non-rebreather, are you going to change the amount of O2 getting across? Maybe a little bit. But what do we need to do? Get rid of this. Get rid of the fluid. Well, what's one thing that might work in pneumonia to actually oxygenate the hemoglobin? Well, CPAP, force the O2 across, force that fluid out of the alveoli, okay? Bag valve mask ventilation. If you have a patient who's in failure, who's close to failure, okay, might want to bag them. By putting them on a non-rebreather, it's not going to do much because that O2 is not going to be able to get through this purulent fluid. So the point here is, look at the type of hypoxia, and you got to figure the etiology of the hypoxia and treat the etiology of the cause. Now you have another hypoxia called anemic hypoxia. And anemia is basically you don't have an adequate amount of red blood cells, okay? But in this case, the anemia is not necessarily meaning that it's like a genetic condition or something of that nature. Anemic hypoxia just means you don't have an adequate number of red blood cells that has an adequate amount of hemoglobin to actually carry the O2. So in this case, in anemic hypoxia, you could have more than adequate O2 getting into the alveoli. Great ventilation, great conduit down to the alveoli, but you don't have the red blood cells and the hemoglobin to pick up the O2 that's available in the alveoli. If you think about your patient with the right upper quadrant stab wound, okay, you pick up on the street, and we said, well, they're suffering from anaerobic metabolism because they have inadequate tissue perfusion, and their cells are hypoxic. What kind of hypoxia are they suffering? An anemic hypoxia. This patient had a respiratory rate, if I'm not mistaken, of 32 with an adequate tidal volume. They're bringing in a ton of air into the alveoli. They're bringing in a lot of O2 into the alveoli. By putting the patient on a non-rebreather, are you really going to fix the cellular hypoxia? Nope. Why not? Because you don't have the hemoglobin available to transport the oxygen to the cell. Okay, are we going to put the patient on a non-rebreather? Yeah, because the trauma surgeons still want us to. But does it mean that it's fixing the cellular hypoxia? No, it doesn't. Until you restore the hemoglobin, it's not doing much at all. Okay, get to the etiology of the cause of the hypoxia. Okay, all right, we already did that. Ischemic hypoxia, and again, would be a poor perfusion state, and this is typically dealing with not the blood loss, because the blood loss, you're losing the hemoglobin. You're losing the red blood cells, you're losing the hemoglobin. Ischemic hypoxia is where you still have, well, I mean, it could be a low blood volume too, but in this case here, you're not losing it onto the street, you're not losing it into the abdominal cavity. This may be from another condition where it may be a third space loss, maybe, some metabolic cause, you're losing volume and so forth. But it's a poor perfusion state, pump failure. You can't move the blood, vasoconstriction. You have massive vasoconstriction. First, maybe a toxic exposure, low blood volume from maybe you have a patient that's, heat exhaustion patient where they're losing volume and losing electrolytes, decreased systemic vascular resistance. You have a patient that has massive vasodilation. Maybe it's your early septic shock patient, cardiac arrest with ROSC. Stroke, MI. These are all ischemic hypoxia. What does that mean? typically you have adequate oxygen and you have an adequate amount of hemoglobin because you have an adequate of red blood cells because they're not in your belly, they're not on the street corner, okay? But you just can't move the O2 and the red blood cell to the cell for some reason. There's heart failure, there's a blockage, there's not enough pressure, whatever it would be. So that causes the cell to become ischemic. That's an ischemic hypoxia. Again, putting them on non-rebreathers to change it? No. What do you have to do? Increase the pump function, increase the perfusion, increase the pressure. Whatever it is, decrease the SVR. Whatever it is, you have to reverse in order to reverse the cellular hypoxia. Get to the etiology of the cause. So will non-rebreather 15 liters per minute be effective? Yeah, no, it won't. Now, here's an interesting one, histotoxic, also known as cytotoxic hypoxia. And this is typically due to a toxic exposure, could be due to alcohol, could be due to drugs, and so forth. But what a histotoxic, histo refers to cells, cyto is cells, hypoxia, the hypoxia is at the level of the cell. In these situations, typically your oxygen is perfectly fine. Your hemoglobin is perfectly fine, but the cell itself can't use the oxygen. In this case, this is a cyanide poisoning. What happens is, with the cyanide, it interferes with the ability in the mitochondria for aerobic metabolism to take place. It doesn't allow the oxygen to actually be used in the mitochondria, okay? So therefore, we have all this O2 available. We have a normal SpO2 on this patient. They have an SpO2 of 97, 98% on room air, and in a cyanide poisoning, their cells are severely hypoxic. They're severely hypoxic because the cyanide is inhibiting the ability of the mitochondria to actually take on the oxygen and use the oxygen to keep them in an aerobic metabolism. What happens to the ATP production? It's going to hit the toilet. What are we going to see in this patient? Significant decline in mental status and cellular function and so forth. Is this patient going to get a non-rebreather at 15 liters per minute? Sure. Sure they are. Because these patients are going to need, the massive O2 because of the lack of O2. You're trying to get as much O2 into that cell, into that mitochondria as possible. But what do they need? They need a cyanide treatment to do what? Reverse the effects of the cyanide so that mitochondria can actually now start taking on the O2 and going through a normal cellular metabolism. So that's an example of a histotoxic or cytotoxic hypoxia. Those are your different types of hypoxia. So this is interesting. So if I said, what are early signs of hypoxia? There's a fair amount of people out there would say, well, cyanosis. Well, cyanosis is a late sign of hypoxia. Unless you have, it's funny, well, no, it wouldn't even be the anemic patient. It's funny. The anemic patient actually would show cyanosis really late. But cyanosis is a late sign, a really late sign. When you see cyanosis to the nail bed, cyanosis to the lip, cyanosis to the conjunctiva, the tongue, the oral mucosa, you're way behind at that point. You are way behind at that point. So what are early signs? One of the earliest signs of hypoxia is pale, cool, and clammy skin. It's a very early sign of hypoxia. And it makes sense. It makes complete sense. The brain, we know, is extremely sensitive to oxygen and the level of oxygen in the blood. And the brain gets very irritable when it doesn't get an adequate amount of oxygen. So we already said, how does oxygen get to the brain cells? Well, through perfusion, right? Through adequate perfusion. And so we know one thing, if we have adequate perfusion, we're going to get O2 to the brain cells. And the brain cells are going to be happy. They're going to go through aerobic metabolism. They're going to produce ATP. They're going to function. So how is pale, cool, and clammy skin an early sign of hypoxia? Well, when the brain is not getting an adequate amount of oxygen, what the brain thinks is, if we could increase perfusion to the brain, we could increase the amount of oxygen getting to the brain. Well, what are two ways to increase perfusion? Well, I'm sorry, what's a way to increase perfusion to the brain? Increase the blood pressure. What are two ways to increase the blood pressure? Increase cardiac output and vasoconstrict. Well, how do you increase cardiac output? You increase the heart rate and you increase the stroke volume. You increase the force of contraction. Well, you vasoconstrict. Well, when your body vasoconstricts, what is it primarily vasoconstricting? The periphery. You're taking that nice, warm, red blood and you're shunting it to the core of the body. And so what do? You create a pale and a cool environment in the skin. Why does it become clammy? Because you're vasoconstricting primarily through first a neural response, where it's direct nerve fiber, but that can't last very long. So within minutes, your adrenal gland starts pumping out what? Epinephrine and norepinephrine. Epinephrine, alpha 1, alpha 2, beta 1, beta 2. Norepinephrine, primarily alpha 1, alpha 2. What does the alpha 1 do? Alpha 1 stimulates your sweat gland. Now we got all this epinephrine, norepinephrine out there doing what? Constricting the vessels and also stimulating the sweat gland. By constricting the vessels, we're shunting the blood to the core of the body. Skin becomes pale and cool because we don't have the nice warm red blood out there anymore. It becomes clammy because of alpha stimulating the sweat gland, causing you to sweat. So not only pale, cool, and clammy skin, but also what's the other one? Tachycardia. Why the tachycardia? Because the brain thinks if it could raise the blood pressure, it's going to get more oxygenated blood to the brain. And what's the two ways, most effective ways to try to raise the blood pressure? Vasoconstrict, increase cardiac output through increasing the heart rate. And the patient might even say, I feel my heart pounding in my chest. That's that increase in stroke volume. Pale, cool, and clammy skin is a very early sign of hypoxia. If you're looking for cyanosis, you're way behind the ball game. Okay, you guys want to take another quick one? Can we do a 5-minute break this time, Matt? 5 minutes, come back at 8:10, quick pee break.
Sure, 5 minutes. This is a good time for everybody to put their hand up for me so we can check attendance. I appreciate that. We have 100 people in attendance. Okay, if you guys wouldn't mind, please put your hand up so that we can take attendance.
I hate to put them on blast.
All right, this is Matt. I'm going to share my screen for a minute so that people can see who's still missing, who doesn't have their hands up. This is all part of keeping track of who's in the meeting.
Do you need me to give you control, Matt?
Okay, you guys, you can see the list over here. We need to take pictures of the list on each break so that we can make sure that everybody's staying on. I don't want to call people out by name if I don't have to.
Caitlin Tom Camp in the chat, Eric Miller in the chat, Brandon Fair in the chat, Richard Jacob in the chat, Williamson in the chat, Connor's in the chat, Lauren David in the chat, Blazer in the chat, Robert Gold in the chat, Paul Bear in the chat, Andy in the chat, Matt Dorsher in the chat, Ronnie Connor in the chat, Hutchinson's in the chat, Mallory's in the chat, Juju's in the chat, Jason's in the chat. So Frank is in the chat, Tom Newman's in the chat, Connor's in the chat, Derek H is in the chat, Madison Rodriguez in the chat, John Gotti in the chat, Daniel Shane is in the chat. So we still need Pontiacs.
All right. Did anybody else go into the All right, following people need to put up their hand if they can. Al Rivalski, Kate Ronyak, Eric the Mayor Miller,
Miller's good.
John Guy, Caitlin Camp,
John Guy's good.
Julie Knowlton, Christina Molina, Bill Glaser. The folks watching with Ronnie, Tony, Dan, and Ronnie, please put your hand up.
Hey, Matt, just so you know, we're all here. We're just casting it to the TV. We already had our hands up on our separate accounts.
Joe, when you start back up, you're going to have to reshare your screen.
Okay. Got it, Matt? You guys seeing the PowerPoint?
Yes.
Okay.
Yes.
All right, let's go ahead and keep going here. Very quick upper airway issues. So a couple things I want to mention here is, notice this big thing right here called your tongue, okay? And there are muscles that maintain the tension on this tongue. They're called submandibular muscles, okay? And the thing that occurs is if the submandibular muscles become flaccid, then you lose the tension on the tongue, and the tongue has a tendency to fall back and occlude the hypopharynx right here, okay? But also keep in mind, look at the submandibular muscle and then also look at the relationship with the epiglottis right here, okay? So what does that mean? Well, if the submandibular muscle becomes flaccid, not only does the tongue have a tendency to fall back, but the epiglottis has a tendency to collapse over the glottic opening, okay? And so you say, okay, so what's the big deal about that? Well, the importance of that is nothing more than that's the epiglottis right there. It'll have a tendency to fall forward with the tongue and close the glottic opening. The key here is that when you're ventilating a patient, okay, and you're using a nasopharyngeal or you're using an oropharyngeal airway, okay, so you're using a mechanical device to maintain the airway, all right, and it's a nasopharyngeal or an oropharyngeal airway, one of the things you have to remember is before you inserted this airway, you had to do some type of manual maneuver, and that would be either, the head tilt chin lift, or jaw thrust. And by doing that, by manipulating the jaw and the mandible and pulling it forward, what you're doing is you're putting tension on those submandibular muscles. And you're not only pulling the tongue forward, but what you're doing is you're also manipulating the epiglottis and pulling the epiglottis up off of the glottic opening. Okay? So in order to pull that epiglottis up, you have to manipulate the jaw. You have to pull the jaw forward with either the chin lift or the jaw thrust. So what does that mean? Well, we know one thing. When you insert an oropharyngeal airway, okay, or you insert a nasopharyngeal airway, if they're down at the level of the epiglottis, then you didn't measure them correctly, and you got a whole nother issue to deal with, like laryngeal spasm and so forth. But we know one thing: they only clear the tongue, but they do not allow the epiglottis to be cleared. So that means if the muscles are flaccid, the submandibular muscles are flaccid, and the tongue is falling back, well, it may fall back against the oropharyngeal airway, and you create an open airway here, or the nasopharyngeal airway, and it's creating an open airway here. But one thing that's not going to be open adequately is the epiglottis because of the flaccid submandibular muscles. So what does that mean? The bottom line is this in your clinical care. Anytime you have an oropharyngeal airway in or a nasopharyngeal airway in, you still have to maintain a jaw thrust, a chin lift where you're manipulating, the chin and mandible forward, or a head tilt chin lift. You have to pull that mandible forward in order to actually pull the epiglottis up away from the glottic opening. Because by simply putting these airways in, they don't reach down to the epiglottis, and you still could have an airway in and still have a partial obstruction at the level of the epiglottis. So anytime you have a nasopharyngeal or oropharyngeal airway in place, you still have to maintain manipulation of the jaw through a head tilt chin lift, an exaggerated chin lift, or a jaw thrust. Okay, anybody remember this? I forget what it's called, some kind of screw, jaw screw or something like that. Yeah, this was a novel device that was out when I was working as a paramedic in the early 90s, and that was supposed to be able to open the airway of a patient who was seizing. It was a corkscrew device, and all it did was broke people's teeth. They aspirated them, and it was just a nightmare. It was one of those devices that had absolutely no clinical study behind it, so they didn't last long. Ventilation, I'm going to cover very quickly, but ventilation is very important. And again, I'm just going to go through this very quickly because you should have already learned this, but this is exceptionally important, understanding how ventilation impacts the patient and impacts perfusion. So ventilation is based on it's actually Boyle law. I found out it's not Boyle's law, it's Boyle law. But Boyle law said basically that the volume of a gas is inversely proportionate to the pressure. So that means as the pressure becomes negative, it's inversely proportionate. As the pressure goes down, the volume goes up. As the pressure goes up, the volume goes down. Well, what do we know? On ventilation, here's what we know. On ventilation, by increasing the thoracic cavity size, well, let me see here. Yeah, let's just do this. By increasing the thoracic cavity size, I'm going to go skip for one thing. How do you do that? You actually, it's an active process. You contract the muscles. You contract the external intercostal muscles. You contract the diaphragm. The diaphragm moves downward. The external intercostal muscles pull the chest upward and lifts it upward. And by doing so, you increase the cavity size. Okay. By increasing this closed cavity size, you make the pressure inside negative. Based on Boyle law, negative pressure increases volume. So what does that mean? Because the pressure is negative, and it may be only 758 millimeters of mercury, out here at sea level at 760, what happens? Air flows into the thoracic cavity. Air is going to flow in until what happens? You reach 760 millimeters of mercury pressure inside because it's 760 out there, and air is going to stop flowing in. The more negative pressure you create inside the thoracic cavity, the more air is going to be able to flow in, okay? And again, how do you create that negative pressure? You increase the thoracic cage size by contracting the intercostal muscles, external intercostals, and contracting the diaphragm. You're contracting. That means it takes work to contract. And because it takes work to contract, you need energy in the form of ATP. Those respiratory muscles need ATP. And because it's requiring energy, it's considered an active process. So inhalation is an active process. It requires energy in the form of ATP, okay? And what it's doing is that ATP is actually allowing the muscles to work, to contract. Diaphragm drops, intercostal muscles contract, pull the rib cage up. And again, you create a negative pressure, you draw air in. So then on exhalation, it's considered a passive process because on exhalation, what happens is there's no energy expended. Because what happens on exhalation, and this is all a timing done with the DRG and the VRG in the brain, and what happens is you lose the impulse to the respiratory muscles coming from the brain to contract, and when they shut off, the muscles relax. And when the muscles relax, they don't need energy. But when the muscles relax, the chest size cavity decreases in size because the muscles are relaxing. The diaphragm relaxes and it comes up. What happens? By doing so, it decreases the size of the thoracic cage and it increases the intrapulmonary pressure. Based on Boyle's law, if you reduce the pressure, okay, or I'm sorry, if you increase the pressure, you reduce the volume. By increasing the pressure inside the thoracic cavity to, let's say, about 763 millimeters of mercury, it's higher than the pressure outside. Air flows which way? Outside. The air is going to be pushed out of the thoracic cavity based on Boyle's law. But the key here, again, is exhalation, passive process. It doesn't require ATP. It doesn't require energy because the muscles are relaxing. That's a huge key in some of the conditions that you're dealing with, okay? So what happens when you're breathing out, when you're exhaling? External intercostal muscles relax, chest wall falls, diaphragm relaxes, comes back up, decreases the size of the thoracic cavity, causes the pressure to become positive. It's higher than atmospheric pressure. Air flows out, okay? Think, okay, well, that's great. All right. One thing I want to mention here is intrapleural pressure is always negative. Look, if you look at intrapleural pressure right here, during inhalation, the intrapleural pressure will actually dip down. During exhalation, the intrapleural pressure will go up, but it's always negative. If you notice here, here's your positive pressure inside the chest, okay, intrapulmonary. Here's your pressure inside the pleura. The pleural space, remember the space between the visceral and the parietal pleura, that space, that potential space that's filled with serous fluid, is always at a negative pressure. That's very, very important. We're going to talk about that too clinically. So resistance. So if you weight train, it's called resistance training. And when you weight train, your muscles have to work, right? And the greater the resistance, the greater the weight, the greater the muscles have to work. And the greater the muscles have to work, that means that they better produce more ATP because there's a higher workload. And if they have to produce more ATP, they better have more oxygen available. Because if the oxygen is not available, then that means they're not going to have the energy to do the work. So if I took Larry and I gave Larry a 20-pound weight and said, Larry, lift this 20-pound weight in your left arm, and I gave him a 5-pound weight and said, lift a 5-pound weight in his right hand, right arm, although Larry would struggle probably with the 5-pound weight, which arm is going to fail first? Well, obviously the answer is the arm that's lifting against the greatest resistance, because it's going to take what? A lot more energy and a lot greater workload to continue to lift the weight against the greater resistance. The 5-pound weight, no problem. Larry's going to lift this for an hour. Keep lifting it, keep lifting it, keep lifting it. No, it's no problem. I'm going to keep working it. And it's not a problem. I could generate the workload. I could generate the energy. But the 20-pound weight, eventually his left arm is going to fail because the resistance is so high. Here's the clinical application. If I took Larry and I took a garden hose and I duct taped it into his mouth, put the garden hose in his mouth, and I duct taped his nose So the only way he could breathe.
For the record, I'm all for it.
Yeah, I bet, Larry. Trust me, that duct tape, I'm sure, would be covered at the end of that hose. But so he has a garden hose, and Larry's able to breathe through this garden hose. His nose is plugged. He's breathing through the garden hose. Why is he able to breathe through the garden hose? Well, this is let's say a 3/4 inch internal diameter garden hose. Well, because there's very little resistance, right? It's a pretty big tube, and there's very little resistance in the tube. So he's not really working very hard to breathe because there's very little resistance, right? So Larry can sit there and breathe all day through this garden hose because there's virtually no resistance because that tube is large enough. But what happens if I take Larry and I duct tape his nose shut and I duct tape a coffee stirrer straw in his mouth? Immediately, what happens to the resistance he's breathing against? That resistance, because the internal diameter of that coffee straw is so small, that resistance goes dramatically up. We've now gone from the 5-pound weight to the 20-pound weight. We've created an extreme amount of resistance, not only to him trying to breathe in, but also now Larry has to do what? Use energy to get the air out. He has to force the air out. Not only is he breathing really hard to bring the air in, he has to use energy to force the air out. So what happens to a patient when they're breathing against high airway resistance? Not only does their inhalation become more active, meaning that they have to use their respiratory muscles harder and they have to use more ATP. Now during exhalation, it becomes an active process, meaning that they now have to use energy to try to get the air out too. That means they got to use energy, ATP, more of it to breathe in, and they got to use ATP to breathe out. So that means their respiratory muscles are working hard. Now we have a patient with an airway resistance issue, and we said that's going to create a hypoxemic hypoxia, right? And all of a sudden, the cells aren't getting the O2 because you can't get the air into the alveoli because there's so much resistance. What happens to the respiratory muscle cells? They go from aerobic to anaerobic. And they start only producing 2 molecules of ATP because now you need this mass amount of ATP for inhalation, exhalation. They're only producing 2 because they don't have the O2 because they can't get it into the alveoli. What are they going to do? Go into respiratory failure real fast because their inhalation and exhalation becomes an active process where they need ATP. And they're already in a hypoxic state, and the respiratory muscles are changing from aerobic to anaerobic, and they're producing very little ATP. They crash fast. Okay? All right, we know that. I'm not going to go that. All right, so let's see. Okay, I'll get there. Okay, I want to bring up a clinical condition, but let's look at muscles of ventilation, accessory muscles. Okay, so these are accessory muscles of inhalation. Sternocleidomastoid muscle, which elevates the sternum higher than normal. These are accessory muscles. These are muscles you're not normally using. The scalenes elevate the ribs 1 and 2, and the pectoralis minor elevate ribs 3 to 5. The scalenes, you're finding the retractions above the clavicles, and the suprasternal notch retraction. Sternocleidomastoid muscle, you're finding in the neck, where that neck muscle becomes very prominent. These are inhalation accessory muscles, meaning these muscles are being activated when you're trying to breathe in a lot harder. You have to use a lot more effort to breathe in. These muscles are activated, and we're going to see these as, the supraclavicular retraction, suprasternal notch retraction, the obvious sternocleidomastoid muscle, and the ribs 3 to 5, 1 to 2, 3 to 5 retractions too. If you see a patient using their abdominal muscles during exhalation, external intercostal muscles you're not really seeing, but you're going to see them pushing with their abdominal muscles to breathe out. That means they are now using an active process to breathe out. They're trying to force the air out. How are they doing that? By squeezing their abdominal muscles, they're pushing their guts up against the diaphragm to try to push the diaphragm up higher so they could create the inner thoracic pressure higher to try to push more air out. That's why they're doing it. Why are they using these muscles to breathe in? Because if they can lift that chest wall higher and make that thoracic cavity bigger, that means that the pressures are going to become more negative. And according to Boyle law, the more negative the pressure, the more volume of air that's brought in. If you bring more volume of air in, that means that there's going to be more O2. So you're going to see this in a patient that's struggling to breathe in, who's hypoxic, who's trying to move more O2. Here's your sternocleidomastoid muscle. Here's evidence that your scalenes are working. Here's your trapezius muscle here. Pectoralis minor, you're going to see also your retractions in here, okay? Those are muscles of inhalation. Here's retractions here. You can see the retractions, okay, occurring. This is a newborn. Retractions are a lot more prominent in young kids and newborns than adults. You see retraction in kids, it's not indication of respiratory failure. You see retractions in an adult, it's a good indication of respiratory failure. Look at the retractions on inspiration. Notice there's none on exhalation, okay? This is a good indication this patient, if they're not already in respiratory failure, they are going to be shortly, okay? Notice this guy here. We all know, if I had to say, hey, this is the patient, you walk in the house and you even have to ask them their history. You already know. What's this patient? It's an emphysema patient, okay? That's that barrel-chested patient. Again, a lot of times you're going to see the retractions. You see the sternocleidomastoid use. You see the scalene use here. You see the supraclavicular retraction, suprasternal notch retraction, and so forth. Okay, so you arrive on the scene. You have an 18-year-old patient in status asthmaticus. Okay, what do we know about status asthmaticus? Status asthmaticus is an airway issue. It's an airway resistance issue. The alveoli are fine. The hemoglobin is all there. The red blood cells are all there. This is a conduit issue. This is where you take the garden hose in Larry's mouth and you change it out for that stirring straw. What happens? You dramatically increase the airway resistance, and they now go from an active inhalation and passive exhalation to an active inhalation and an active exhalation. They're using their respiratory muscles. They're using accessory muscles. They're using a ton of ATP to breathe. Breathe in and a ton of ATP to breathe out when they're hypoxic. So what is going to happen? Well, when they're hypoxic, they're going to fail fast because they don't have the ATP production, because they don't have the O2 being delivered to the respiratory muscles. So we say, so what are we going to see? Well, we're going to see an increase in respiratory rate because they're trying to move more air, and that's not effective because they can't move it against the conduit. They're just going to fail faster. We're going to see decreasing SpO2s. We're going to see decreasing awake or aware status. Okay, so they're going to have cognition issues. Okay, we're going to find that they're becoming sleepy. This sleepiness is from a collection of CO2. The sleepy and confusion, sleepy confusion status or state is from high CO2. CO2 is starting to collect. Remember, CO2 breeds acid. The agitation you see in patients, the agitation, the aggressiveness, that's from cerebral hypoxia. Cerebral hypoxia causes agitation and aggressiveness. The sleepiness is from the high CO2, and the confusion is from high CO2. When a patient suddenly becomes compliant with your treatment, they're fighting you, and suddenly they become compliant. The immediate thing you have to look at is my patient now in respiratory failure? Okay. And if their mental status is not improved and their SpO2 is not going up and their heart rate's not going down, their respiratory rate's not going down, they're in respiratory failure, and their next step is they're going to be in cardiac arrest, respiratory arrest, cardiac arrest. If they're head bobbing, they are too weak to keep their head up. Okay, they're too weak to keep their head up. That's an indication that if they're not in failure, they're going to be a decreasing tidal volume. They're just not bringing enough air. Severe pallor, diaphoresis, you're going to see cyanosis, you're going to see retractions. Abdominal muscle use is telling you they're working hard to breathe out as much as they're working hard to breathe in through the retractions. This patient, if you're seeing this patient's in failure. This patient needs bronchodilated, and they need steroids to reverse the inflammatory process, and this patient is going to need ventilated, okay? Be careful with your ventilation. Don't want to overventilate them, okay? All right. We talked about that already. Anybody ever do this? Water glass effect. You ever take like a glass tabletop? You could do this on a bar. Not that any of us ever been to a bar before. And you pour water on it, pour water on the glass top, okay? Then you set a glass firmly down and you press down right in the puddle of water. Then you lift straight up. And what happens? Here's an example. Okay, so they poured water on here. You can see some of the water here. Here's a glass. Here's something that's a non-porous surface, okay? And you push down and then you lift up, and all of a sudden you're lifting the glass up. You're lifting this whatever this is up. This is called a water glass effect. What happens is the water forms a seal around the glass. And by you lifting up against this stationary structure, you're creating negative pressure inside the glass. That means you have negative pressure because you're pulling up against this structure that's stable in this water that's forming a seal, and you're pulling up and you're creating a negative pressure. It's called a water glass effect. Well, believe it or not, we all have this water glass effect that is actually found in our thoracic cavity, okay? Because what we have is this. Remember I said that your intrapleural space is always negative. Why is that? Well, here's your lung tissue, okay? Now, your lung tissue is made up of, again, this is very elementary, but it's made up of collagen, but it's also made up of elastin fibers. And elastin sounds like elastic. And we know one thing, when you take elastic and you stretch it and you let go, it recoils. Because that elastic, like a rubber band, wants to recoil to as small as it can be. Your lung is made up of elastin. That means if you allowed it, your lung would collapse to 5% of its size because of the elastin fibers. Your lung wants to collapse. It doesn't want to be expanded. It wants to collapse. And if you allowed it to collapse, again, it'd be 5% of its size. But your lung can't collapse. So here's your lung tissue here, okay? Here's your intrapleural pressure here. Don't worry about the pressures right now. And here's your thoracic wall. What do we know about the thoracic wall? Well, it's a pretty stationary wall. You know, it doesn't move a whole lot. It moves with inhalation, exhalation, and so forth, right? And what do you have? You have your parietal pleura here that's adhered to the thoracic wall, and you have your visceral pleura here, which is adhered to the lung tissue. Remember I said this is your pleural space. This has serous fluid in here. And this serous fluid does what? Creates a seal. And what do we have? Constant pull inward by our lung tissue. A constant pulling inward because our elastin wants to take that lung tissue and collapse it. But what's not allowing it to collapse? The thoracic wall, because it's pretty stationary. So because the lung is constantly pulling inward, what is it creating here? A water glass effect. So that means what? During every phase, inhalation and exhalation, the intrapleural pressure remains negative. Even during exhalation, when this pressure in the intrathoracic cavity is positive, the intrapleural pressure is negative. What does that mean? That if you poke a hole through the thoracic cavity, or you poke a hole through the visceral pleura through the lung into this intrapleural space, you're going to do what? Suck air in. And suck air in. And suck air in. What do we know? Each time inhalation occurs, and this pressure is becoming negative, and the pull is becoming greater because the thoracic cavity now is expanding, it's pulling, and it's pulling the lung tissue with it because the lung tissue doesn't want to go, and it's creating a negative pressure here. This pressure becomes even more negative. So this is an inhalation. On inhalation, intrapleural pressure is 758. Look, intrapulmonary pressure is 758, intrapleural 754. That means if there's a hole in here, where's the air going? Right into the pleural space. Right into the pleural space. Then on exhalation, as the chest wall relaxes, the lung is still pulling. This this pressure may go to 758 while it's 760 here. 760 out here, 758. Air is still being sucked in. What do we create? We create a pneumothorax. That's how pneumothorax is created. And this will continuously take on air, and my lung tissues can continuously going to pull until it's what? Completely collapsed. Until it's completely collapsed, at that point, this lung tissue is not going to be happy, and this intrapleural pressure is going to be negative. Okay? Makes sense? That's how pneumothorax develops. So what do we know about this? Look at this here. What is this? What is this? This is one thing I taught everybody. This is your open, true, sucking chest wound. What phase are they in right now? Exhalation. How do we know that? Because it's bubbling. Because air is actually, some of the air is being pushed out because the pressure inside has become positive in the intrapulmonary space. Okay. Then on the next inhalation, what are you going to hear? The sucking sound. Okay. All right. So what's the point to this? Any open wound to the thoracic cavity, you need to cover it with a non-porous dressing. Okay. Whether it's plastic bag, whether it's saran wrap, whether it's the Asherman seal, whatever it is. Use whatever it is, but if you have, like this guy was shot with the shotgun, obviously a double out buckshot, the large pellets. You got to cover all these with non-porous dressings. Thoracic cavity, anterior, laterally, and posterior. Do not forget, lift the arms. Check under the arms to make sure that your patient doesn't have a stab wound, gunshot wound, open wound to the thorax, anywhere to the thoracic cavity if there's an open wound, because if you don't cover that open wound, that intrapleural pressure is always negative, and it's going to want to bring that air in and cause the pneumothorax to continue to evolve and evolve and evolve. Okay? That's the guy shot with the double-out buck. You can see none of the pellets actually penetrated his chest. They're all stuck in the subcutaneous tissue in the muscle. This guy wanted to commit suicide, so he took, that's obviously an old picture because look at the antenna. He took the antenna off his car and he stabbed himself in the chest. He must have been having a really bad day. This is a bad day right here. Yeah, really bad day. Now here, what do we know? We never remove an impelled object. Never, ever remove an impelled object. What you would do in this case, you would take non-porous dressings, put it around this opening, stabilize this, and, then go ahead and transport the patient. Okay, whether you cut this or not, that's up to you, depending, but you don't want to do this. You don't want to agitate. Look at this. This is probably this guy's left ventricle or something. You pull it out, you could, cause pericardial tamponade. It's like Steve Irwin, the crocodile hunter or whatever his name was, when he got stung by that stingray. The worst thing that he did, and they had these pathologists look at this, and the worst thing he did was when he got stung in the chest, it went into his left ventricle. If he would have left that barb in there, he would have survived. They all said this guy would have survived. But what he did was he immediately pulled it out. And when he pulled it out, he created a hole in the ventricle that then created a massive pericardial tamponade, and he died from a pericardial tamponade. Okay, let's talk about this a little bit. Minute ventilation, alveolar ventilation. Minute ventilation, and you say, well, what's the relevance of this? Well, if you want to know whether your patient is breathing adequately or not, you have to know something about minute ventilation. Because the two things that you assess for whether your patient is breathing adequately or not is tidal volume and the rate that they're breathing. Okay? So minute ventilation basically is the amount of air moved in and out of the entire respiratory tract and alveoli in 1 minute. Okay? You take the tidal volume, the amount of air they breathe in with each breath, and you multiply it times their rate, which is how many times are they breathing per minute, and you come up with the minute ventilation. Average size adult breathes about 500 mLs with each breath, and they breathe at 12 times a minute. 500 times 12 is they move 6,000 mLs or 6 liters in 1 minute. Average size adult moves about 6 liters of air in 1 minute. Okay, that's their minute ventilation. How much ventilation are they moving in 1 minute? What do you assess? Tidal volume and rate. Are we going to calculate these in the field? No, that's ridiculous. But there's a concept behind this. So you say, well, then, but how much of that air really gets into the alveoli? because you got to fill first the respiratory tract, all that dead air space, nasopharynx, oropharynx, hypopharynx, the bronchi, the trachea, the bronchi, the bronchioles, and the alveoli. You got to fill all that. So you say, well, there's a hell of a lot of dead air space. How much of that really gets to the alveoli? Because we know if the air is not in the alveoli, there's no gas exchange. It doesn't matter how much air you put in the trachea, the bronchi, the bronchioles. It's how much air do you get into the alveoli to determine your gas exchange and the oxygenation state of the cells. So in order to determine how much air gets in the alveoli, you take your tidal volume and you have to subtract off the dead air space. Then you multiply it times your rate. So you take your tidal volume minus the dead air space. Average size adult has 150 mLs of dead air space. That gets filled first, okay, with the volume. And take that times 12, 350 times 12. So it means out of the 6,000 mLs of air you're breathing in 1 minute, 4,200, an average size adult, makes it into the alveoli. The remainder of that air actually then is stuck in the dead air space that's not used in any oxygenation of any hemoglobin, okay? So you say, okay, so I have a patient now who is breathing shallow, and I'm going to estimate that their tidal volume is 200, average size adult, 200, but they're breathing at 28 times per minute now instead of 12. So their minute ventilation is 5,600. You're like, well, a normal minute ventilation for this patient is 6,000. So obviously, if they're breathing 5,600, they're not doing bad at all. I mean, hell, this patient's doing pretty good. They're almost normal at 6 liters per minute, 6,000 mLs per minute, right? Well, you say, well, what did I say? Tidal volume. The tidal volume first fills the dead air space. You got to fill all the dead air space before it gets to the alveoli. So you say, well, let's look at the minute ventilation or the alveolar ventilation. When we account for the dead air space, they're only moving 50 mLs of air with each breath into the alveoli instead of 350. And although they're making up for minute ventilation by increasing rate, look at their alveolar ventilation. This should be 4,200. This is near normal by increasing the rate. This is in the toilet. This patient is severely hypoxic. Although minute ventilation looks like they're breathing okay, this patient is severely hypoxic. So the key here is don't just look at rate. You got to look at volume, tidal volume. A shallow tidal volume means you have to ventilate your patient. Although this patient is breathing at 28 times per minute, this patient is likely in a severe hypoxemic hypoxia because they're not moving enough air in the alveoli. And their cells are probably already shifting from aerobic to anaerobic metabolism. They're producing very little ATP. I'm sure their mental status is affected. I'm sure their respiratory muscles are beginning to fatigue because they don't have the energy. What do you need to do? You need to get this back up to 4,200. How do you do that? You override ventilate them. So that means every fifth or sixth breath that they're taking out of the 28th, or I'm sorry, every 5 to 6 seconds that they're taking a breath, you're going to impose a ventilation with a tidal volume that would be around 500 mLs, okay, or less. We're going to talk about that in a little bit. But you're going to ventilate enough to see adequate chest rise. What's your indicator? Not keep squeezing the bag once the chest rises. As soon as that chest rises, you cut off your ventilation. That is going to be your adequate ventilatory volume. As soon as that chest rises, stop ventilating. And you're going to ventilate, override ventilate 12 times per minute. Not 28, because you're ventilating 28 times per minute, it's way too much ventilation. But you have to actually supplement that. Never be afraid to override ventilation in these patients, okay? All right. In order to have adequate breathing, you got to have two adequates. You got to have an adequate rate. You have to have an adequate tidal volume. But in order to have inadequate breathing, inadequate means they're not breathing adequately. If it's inadequate breathing, you got to ventilate them. It's either an inadequate rate or an inadequate tidal volume. Tidal volume is not enough, or the rate is not adequate enough. An adult patient breathing at 40 times per minute, okay, is quickly going to go into respiratory failure. An adult breathing at a rate of 40 times per minute. One, because they're breathing so fast, their tidal volume is not enough because their respiratory rate is so fast, they can't bring enough air in with their next breath because they have to do what? Exhale real quick to take on the next breath. So they're going to become hypoxic. The cells are going to be hypoxic. They're going to lose the ATP. They're going to lose the respiratory muscles. They're going to quickly go into a respiratory failure. Pediatrics breathing at 60 times per minute will fail quickly. They can't sustain 40 in an adult, 60 in a pediatric. Okay. Chemoreceptors we talked a little bit about. I'm going to skip. Oh shoot! I'm going to skip over this. Respiratory muscles. This is interesting. You breathe based on your stimulation from your brain. You have VRG and a DRG, and the VRG turns on, and all of a sudden you inhalate. So what it is, this is like the brain, the VRG in the brain turns on, and it sends impulses, literally sends stimulation to the external intercostal muscles, the diaphragm. And when they get stimulated, what do? Contract, and the muscles move up, pulls chest wall up, diaphragm goes down, and what do? It's stimulated for 2 seconds. After 2 seconds, what happens? The brain stops sending the signal. So what happens? The respiratory muscles relax. You have 3 seconds of relaxation, and then all of a sudden, what does the brain do? Boom, turns back on again. Boom, 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 boom. Respiratory muscles get innervated by the stimuli. Muscles contract, you breathe in. After 2 seconds, boom, brain shuts off. That's how you breathe. That's how you breathe based on, okay, it's 8:50. I'm going to skip through this. I was ventilation perfusion. Let me show you this. This is interesting. Check this out. Flail segment. Okay, look at this. Look at the movement of the chest. Okay, on inhalation, this flail segment is moving.
Joe.
You can't see it? Oh, damn it. What are you still seeing my slides? Yeah. All right.
Yep.
That didn't work. All right. Screw it. I got another one. Let me try this. Okay. Let me see. You guys see this?
See that?
Yeah.
Yeah.
We got it. Okay. If you notice on inhalation, look at the flail segment. The flail segment is being drawn inward. Okay. Okay. And on exhalation, on that other video, shows it a little bit more prominently, the exhalation, where the flail segment moves outward. Okay. All right. So here's what happens in the flail segment. Here's why flail segment is so dangerous. Okay. 2 reasons. One, if you have enough trauma to cause 3 or more contiguous ribs to break in 2 or more places, you had a pretty significant blow to the chest. That means you have an underlying pulmonary injury. And a lot of times you have an oxygenation issue because you have bleeding around the alveoli, which is going to cause a hypoxia to occur because you can't get the alveoli to get the O2 across the blood area. And the other problem you create is what's called a Pendeluft effect. So if you have a flail segment right here, okay, and you have this section of ribs that are broken, and remember, they're free floating. So what happens on inhalation? The intrathoracic chest becomes negative. Because this is a free floating segment, what happens? The negative pressure, what does negative pressure do? It sucks. So what does it do to this segment? It sucks it inward. Whoops. It sucks it inward because it's negative. It's sucking that section inward. But what does it do to this right lung? Makes it more positive. Now, the left lung is real negative, and because it's more positive, what happens? The air goes over to the left side of the lung. But then on exhalation, when the chest wall is relaxing and coming down, and the pressure inside the thoracic cavity becomes positive, positive pressure does what? It pushes. It pushes the segment outward. And when it pushes the segment outward, what does it do? Increases the size of the thoracic cavity. Based on Boyle law, if you increase the size, you're going to reduce the pressure. You're going to suck air back on this side. So you see what happens? The Pendeloft effect is you take air from here, you suck it into here. On exhalation, you suck it into here. On inhalation, you suck it in here. All of a sudden, you have still air being sucked from one lung to the other lung, the injured lung to non-injured lung, non-injured lung to the injured lung. That's the Pendeloft effect. You say, well, what do you do with it? Well, the problem with this is the whole problem with a flow segment outside of the underlying pulmonary contusion is the change in pressure. This patient is not breathing adequately because they aren't able to generate the right pressures to actually cause this ventilation to occur normally. So what's your primary treatment? Primary treatment is going to be ventilate them. CPAP is appropriate. Ventilate them. Override pressure, because their problem is they can't create the right pressure in the injured chest, and they create this Pendeloft effect. So what's the best thing you can do for them is you create the pressure, you ventilate them, positive pressure ventilation. Low tidal volume, just get the chest to rise, rate 10 to 12 times per minute. You can use CPAP. Pain management is important. If you can reduce the pain, actually that's going to be a big thing, because they're going to splint. They're going to splint. Here's a patient here with air trapping. Okay, I don't know if this is not a great slide, but you can see on the left side of the chest, it's hyperinflated. That's air trapping there. Okay. It's like your emphysema patient. Barrel chest is not all that common anymore. But why does an emphysema patient develop a barrel chest? Because what do? They do nothing different than this patient. They air trap. The difference, the difference is in the emphysema patient, they air trap over a long period of time, and it changes the structure of the chest from the air trapping. So what's the ventilation dilemma? Okay, this is very important, ventilation dilemma. Can overventilation lead to a poor outcome? The answer is absolutely. Because what you have is what's called a cardiothoracic pump effect. Okay, so what that means is you move blood based on changes in your intrathoracic pressure. We said when the intrathoracic pressure becomes negative, what does it do? It sucks. So what does this suck? It sucks the blood from below the diaphragm back up the inferior vena cava into the right atrium. It sucks blood from the venous side below the diaphragm. Where's the majority of the blood located? Look, it's below our diaphragm. Look at the size of our body below our diaphragm. Sucks it up into the right atrium, into the right ventricle. What does this determine? Then the amount of blood that ends up in the left ventricle right before the contraction. What's that called? Preload. And I know what? If I reduce my preload, I reduce my blood pressure. If I reduce my blood pressure, if I reduce my preload, I reduce my stroke volume. If I reduce my stroke volume, I reduce my cardiac output. If I reduce my cardiac output, I reduce my blood pressure. If I reduce my blood pressure, I reduce what? Perfusion. So it means what? A good negative pressure in my intrathoracic cavity keeps this venous blood filling that right atrium. Okay? The more negative the pressure, the better the venous return. What's the problem? If I take a patient and I provide positive pressure ventilation, listen to the name, positive pressure ventilation. I am delivering a positive pressure on my ventilation. That means when I squeeze that bag, it is delivering a positive pressure in the intrathoracic cavity. Okay? That positive pressure does what to venous return? Impedes it, because the intrathoracic pressure is positive. So what does that mean? The more I make that intrathoracic cavity positive, the poorer the venous return, a greater reduction in the preload, a greater reduction in the cardiac output, a greater reduction in the blood pressure, and a greater reduction in perfusion. The more I make the intrathoracic cavity positive, the more I reduce perfusion. How do you make your intrathoracic cavity more positive for a longer period of time? Ventilate the patient at a faster rate. Ventilate them more than what you need to. You will make the intrathoracic cavity more positive, and you, through your treatment, that you think you're doing good by delivering more ventilation, you're actually reducing perfusion, cardiac output, coronary artery perfusion, cerebral artery perfusion, and perfusion throughout the entire body. So what's the takeaway? You reduce your ventilatory rates. And what does that mean? In a cardiac arrest patient, if you have an endotracheal tube or an advanced airway in place, max ventilation 8 to 10. If you don't have an advanced airway in place, max, not minimum, max ventilation 10 to 12. Think about it. In a cardiac arrest patient, their cardiac output is pretty much, with the best CPR, 5% of a normal cardiac output, 5%. Now you come along and you start ventilating at 24. Remember I told you most paramedics were ventilating cardiac arrest patients at 48 times per minute. Tell me about their perfusion. Tell me about their brain perfusion. Tell me about their heart perfusion. There wasn't any, because they had that intrathoracic cavity so positive that their venous return was so poor that they had no cardiac output. So therefore, by limiting your ventilation rate to 10 to 12, you have to be very aware, very cognizant of this, okay? You are going to improve, actually, perfusion. Acute asthma attack. They trap air. They trap air in their intrathoracic cavity because their alveoli are filled and they can't push the air out because of the high airway resistance. If you take an acute asthma patient and you are ventilating them more than 12 times a minute, you are going to drop out their blood pressure because you are going to decrease their cardiac output by overventilating, because they already have an increase in intrathoracic pressure because they have air trapping. We know that. Look at their chest. It's hyperinflated. Now you come along, you start ventilating because they're in respiratory failure, and you start ventilating them 20 times a minute, 24 times a minute, 30 times a minute. You're going to drop out their blood pressure, their cardiac output, and their perfusion. Tension pneumothorax, same thing.
Hey, Joe, it's Larry.
Yes.
I just want to be respectful of everybody's time. It's 9 o'clock.
Yes. Okay.
So keep that in mind.
Oh, thank you, Larry. All right. It's like the old days. I'm just going to keep going until about 10. No, I'm just kidding. I'm going to finish up here very quickly. Shock. PHCLS says if you have a patient in shock, 10 times per minute max with a volume of 350 to 500. Here's another problem. If you're ventilating them too much and you're creating way too much O2, you create an alkalotic state, and the O2 wants to hang on to the hemoglobin. Why are we doing this in shock? Because they have a reduced venous volume, right? To begin with, we have very little blood getting into the right atrium to begin with. And if we overventilate them, we're reducing that volume even further by causing an increase in intrathoracic pressure. Okay, let me go. Yeah, we're gonna. Okay, here. Okay, we're almost done here. Okay, so Matt, here's the stuff that you want to talk about, real quick. You could do it in 1 minute.
All right. Whoever would have thought that Joe Mistovich would go over?
Ah, sorry.
Hey, this is Matt, and all of this stuff that you just heard Joe talking about today. Just for the record, 20 years ago, or more than 20 years ago, he told me the exact opposite on just about everything. But
true,
you know, EMS is dynamic, and we are evidence-based, and when we learn we're doing something wrong, we change it. And so that's one of the things we're going to try to do here at Trumbull. You see these issues with overventilation. You see these issues with post-arrest injuries, reperfusion injury, and everything. We're looking at a way to reduce that. And one of the things we've come across is reducing that tidal volume. You know, if you imagine that after someone's had CPR and ventilation or a Lucas machine on them and everything, with bag valve mask ventilation, all that injury to the lungs and the reperfusion injury, and then we come in and we start bagging them hard and fast, and we're making their chest rise really far. And it's hard not to do that when you're faced with that situation. So one of the things we're going to be doing is we're going to switch from adult bag valve masks to pediatric bag valve masks. So that's going to reduce your volume. The average volume delivered by an adult bag valve mask is about 807 milliliters, and with a pediatric bag valve mask, about 630 milliliters. So if you look at some of these values that Joe's put up here, it really matches. It matches what we're trying to do. We want to reduce that barotrauma, that volume trauma in the lungs. And, you know, we're not just doing that because we think it's okay. What happened was in some of the studies that we've looked at, I'll just cite a couple of them very quickly. Lower total volume after out-of-hospital cardiac arrest in the one particular study was independently associated with a better neuro outcome, more vent-free days, and more shock-free days in the hospital. And you can see this slide that's up right now. This particular study, this is a different study. When they reduced the total volume of 12 milliliters per kilogram, which was the control, to 6 milliliters per kilogram, which was their intervention, this study was stopped early due to the mortality benefit. The people who were getting 12 milliliters per kilogram, 39.8% versus 31% with the intervened people. This is the outcome, you know, just a better outcome. You're looking at, I mean, that's pretty significant. That's almost a 9% increase in a better outcome, better resuscitation, less neuro damage, less shock, less everything. And if we can do that through something as simple as changing the tool we're using, then that's what we're going to do. For the people who aren't going to use a pediatric bag valve mask, one of the things that Joe reiterated several times is we need to ventilate until we see the chest rise. When the chest rises, stop ventilating. Way back in the day, you know, we both hands on that bag valve mask and pump away. And we're realizing that, you know, we were creating barotrauma to these lungs that was leading to a poor outcome. Not to mention the issues with perfusion, with increasing that interthoracic pressure. You know, we're bagging people and trying to do CPR, and like Joe said, you know, with only 5% moving on the best CPR, when we add all that pressure to there, I have to imagine we're not moving much blood at all in the end. So that's one of the things I want you to look for coming up with Trumbull's protocol. And again, if you don't have Trumbull's protocol, I just ask you to, you know, be cognizant of how you're ventilating your patients, and you know, lay off a little bit if we can. Other than that, I think Larry, did you want to say something, Larry?
I'll let Joe finish.
Okay. But that's, you know, this is where we come with our evidence-based protocols, where we look at something and analyze it and look for studies and try to participate in these studies. And that's what we're going to try and do. But this is actually a pretty exciting deal. You know, right here with the issues with overventilation, you know, they're recommending 10 to 15, but the recent studies at 5 to 8. So that's why we're going to change to the pediatric bag valve mask for a better outcome. Does anybody have any questions about that?
Yeah, this was interesting. Larry sent me the studies. It was very interesting. Because again, this is going to find in the AHA 10 to 15, and and actually they're really on the low end side, like really 5 to 6 mLs per kilogram. But the bottom line is this: we're not going to sit out in the field and go, well, how much is 5 milliliters per kilogram? As Matt said, you know, if you're using a pediatric BVM, you're going to say, oh, as soon as that chest rises. The problem with the adult BVM is we have a tendency to squeeze way too much, you know, way too fast. And here's what the recommendation is: you know, if you take a 220 pound, 6 foot person, it's 100 kilos. I want you to bag 1 liter realistically in the new calculations. And I'm sure at some point, you know, Larry, you're going to have to probably work this in, and we'll work this in another, but they have these new calculations based on height, and you take a 6 foot person and based on their height, they're recommending 468 mLs, more than half of what the AHA was recommending at 10 to 15. So listen, what Matt's telling you too is half a pediatric bag is going to prevent you from overventilating, and you're going to, even if you're not aware of it, it's going to prevent you from overventilating. And again, make sure you're watching your rate too. We're talking 10 to 12 times per minute in the adult patient. In the pediatric, it's going to be 15 to 20. So, and this is interesting too, but we don't have the time to do this. But as Matt's saying, yeah, they've seen great results with reducing the ventilation. But you see why? Because ventilation, overventilation, and over-oxygenation are bad for your patient. Blow out cardiac outputs in a lot of these patients, blow out perfusion in a lot of these patients. So, all right, here's my email address. If anybody wants a copy of the slide set, send me an email, request them. I'll give you a link to my Google Drive. And again, you could use them for reference. You could use them to present as a continued ed. Whatever you want to do with them, I don't care. I'm all about sharing. So I appreciate it. Thank you. I know we went through a lot of stuff in actually a relatively short period of time. So if anybody has any questions too, feel free to email me. Please email me. If you have any questions, I know people want to get off, but if you do have questions, I don't know, Matt or Larry, if there's any hands up. If anybody wants to stay, you guys give the instructions for them to get off. I'd be willing to stay, answer any questions. If not, email me. I'd be happy to answer them. Okay, I'm turning it over to you guys.
Okay. I did see a couple of questions. I saw Steve Malk out there. Steve, did you have a question?
Can you hear me?
Yes.
All right. My only thing, I don't remember if it was one of the intensivists that I follow and whatnot. Their other thing, along with the pediatric bag, is with the adult bags, just not opening it all the way, leaving it how it's the 3-part. You can pull it apart, leave it collapsed.
Yeah, that's interesting. Yeah. It could be another technique. Yeah. Yep. Interesting. Thank you.
Another technique we saw was only use 1 or 2 fingers.
Yeah.
Was there another question out there, Jesse Minio?
The other thing too is that for cost effectiveness, the pediatric bag valve mask, you can get it from the medical supplier. Locally, we use one. They quote us the same price as an adult, so you can actually get more benefits out of a pediatric bag and then add in the adult face mask, and it's going to work just fine. So it's very cost effective.
I was going to say, Larry, make sure that you're using an adult mask when you're doing this, not a pediatric mask.
Yeah, there is one thing. I'm going to share my screen because I want to go over, for those of our providers here, I want to show the new respiratory distress and COPD asthma protocol, and I think it's going to tie in a lot of what we talked about. Okay, so this starting in January, we're going to release these to all of Trumbull protocol, and you guys are more than welcome if you're on a different protocol wherever you're at, whether it's Cleveland, Cincinnati, Columbus, Toledo, down in Portsmouth, or even PA, although PA is a different monster because they have a state protocol. What I want to keep you cognizant of is look at your respective level down here. So if you're an EMR, I want you to pay attention to gray. EMT, I want you to pay attention to blue. AMT, green. Paramedic is red, and then extended will be special privileges, knowing that you passed off on an airway course. So we've now combined all the respiratory distress problems together. And what we were very known for at Trumbull is we're not going to kind of cookie cut anything, and we want you to use your mind. You'll notice that in this protocol, there are no arrows except for when it's relevant. So this is not a stepwise fashion. We want you to be able to think. So by saying that, let's go over this. So first, the patient at the EMR level, we're going to do universal patient assessment, right? So with respiratory distress, asthma, COPD, if they have wheezes, these little black bullets over here, consider the anaphylactic reaction. Maybe they got stung by a bee and that's what's causing the wheeze. So just kind of keep that in mind. We're going to automatically apply the end-tidal CO2 via nasal cannula. Capnography is huge. We're going to hear from Captain Glenn Keating from Delaware County EMS on Thursday. So we're going to apply that capnography early. Because this is a respiratory problem, we want to make sure that the SpO2 is titrated to around 94%. All right. And we know that the COPD patients have a physiologically lower SpO2, so that's okay. We're going to go to our adult airway protocol, and that's not really relevant. That just says when you need to intubate somebody. And as Joe said, we're going to titrate oxygen up from 2 liters per minute all the way up to as necessary. Rule out a cardiac event, and if you can, try to rule out that cardiac event within 5 minutes of patient contact, and that's huge because you might have that cardiac wheeze. You might have that one STEMI patient who actually is wheezing because of the heart failure or anything else that's going on. So try to do that. And if you find that it is a positive STEMI, then we want you to go ahead and follow the ACS protocol. But again, at the EMT level, according to the state of Ohio scope of practice, you can go ahead and you can do a 12 lead, and we want you to transmit that to the medical direction. All right. And that medical direction, if you're under our protocol, will be Trumbull. If you're under a university, it'll be UH. And St. E's doesn't have medical direction. But that's okay. So you're going to do that to your medical direction. They're going to interpret that EKG for you if you're an EMT. Send that as quick as possible. Do your IVIO, whatever you need to do. Draw some labs pre-hospitally. And then if you need to, let's go into this. So if you have wheezes, indicative of that bronchoconstriction that Joe talked about, the standard of care and what we put in is a duoneb 3 milliliters and repeat it as necessary. All right. EMTs are able to do this in the scope of practice, and whatever Ohio says you're allowed to do, we put it into our protocol. So EMTs will contact Trumbull because it's our protocol for medical command. Contact your medical command, follow your orders, and do the duoneb as necessary. I know that we've kind of said 3 is historically in the max, but it really doesn't matter. If they're improving, continue to do that. In the hospitals, they do long-term 15-minute nebulizers. So we're just going to make sure we open them up as necessary. Get your steroids on quickly. Get your steroids on quickly. So if you're putting somebody on a nebulizer, make sure you're giving them that Solumedrol right away, and that is a paramedic function. But if they're not improving and there's a ventilatory problem, then we're going to go quickly to CPAP. And we want our CPAP of 5 to 10 centimeters. And again, this is at the EMT level that you can go ahead and do that. Here's what's new and cutting edge. If that CPAP's not working and they still have that COPD, emphysema, wheezing, we're going to go ahead and allow the advanced EMT to give ketamine at 0.5 mg per kg IV. And this is interesting because ketamine will actually open up the bronchi and allow you to get more air in. And not only that, it's going to allow, when that bronchi opens, it's going to allow a little bit of increased ventilatory and increased respirations to allow that medicine to get in everything that we're doing. So we're going to give that IV. If that still doesn't work, then we're going to go ahead and say, you know what? Do your mag sulfate. And mag sulfate at the paramedic level has gone huge the past couple of years because of COVID, because you weren't allowed. They didn't want you to go ahead and nebulize and aerosolize that COVID virus all over the place. And then if it's still, you've gone all the way down here, or maybe you're on an advanced car and you don't have the ability to give mag sulfate, go ahead and give your epi. Give your epi IM just like you would do it for anaphylaxis. Go ahead and shoot it into the leg. And that's going to have those alphas and betas, but specifically betas. And beta 2, you have 2 lungs, so beta 2 receptors will allow you to go ahead and bronchodilate too. We literally have given you every tool in the toolbox pre-hospitally that you can use to bronchodilate. There is nothing else pre-hospitally that you can do according to the state of Ohio that we're not letting you do. So what you're going to do, listen to the lung sounds. You realize that they're wheezing, they have constricted bronchi, give the duoneb, put those steroids on quickly, try your CPAP right away. If not, the advanced in the state of Ohio, give some ketamine. That's going to open up those bronchi. And if you need to, if they're anxious because you put them on that CPAP, go ahead and give a little bit of Versed. We're practicing medicine. That Versed, you might say, well, Larry, that's going to decrease and sedate them. That's not a bad thing because if you're struggling to breathe, as Joe said, you're already hyperventilating. We're mixing medicine. We're putting them together. This is cutting edge stuff, and this will do your patient a lot of good. Steroids, epi, and if not, when we get further down, we're going to do delayed sequence induction. And pretty much all that is you have the patient on CPAP, and we're going to sedate them so that we can control their respirators. That ketamine is already on board. They're going to be sedated. And you might say, well, Larry, I was told that I can't use CPAP on anybody who can't maintain their own airway. And then I'm going to tell you, how do sleeping patients use CPAP at night? They're not consciously alert. Do we hyperinflate their stomach? Do they vomit? No. So the CPAP, when we kind of put them into like a little twilight with the ketamine and we start to do all this stuff, that's going to work, decrease intubation rates and decrease that patients from getting poor outcomes. So everything that we can actually let you do, we're letting you do. And again, maybe you want to go and you want to you feel the need that you need mag sulfates first. Go ahead and do it. These are suggestions. The only two go from one thing to the other, the arrows, CPAP, then the ketamine. If not the ketamine, then, try this. But again, the advanced out there, you can do your DuoNeb, you can do your CPAP, you can do your ketamine, you can do your epi. For the medics, you're going to do all of that, plus the Solu-Medrol, the mag sulfate. So this is really cutting edge stuff. I think you guys will enjoy it if you're under protocol. And if not, go and rally to your respective protocol providers and say, look, this is evidence-based. This is what we're doing. Hopefully we can get everybody on board doing the same thing. So we need to come into our ERs. It's working very well. So that's what I wanted to kind of like reiterate on that. Does anybody have any questions with what I talked about there? No? Okay. So look forward to that for January. We're going to release it, and on top of the pediatric BVMs and whatnot, and you guys will be almost under a protocol. This is one of 4 protocols in the nation that are allowing this to happen. So very cutting edge, and we're going to continue to be progressive. And that's all I've got.
All right. How about that? So I appreciate everybody, the folks that stuck around a little bit longer for the conversation. I'm willing to hang out as long as anybody needs us to hang out. Other than that, really, really appreciate your time. I appreciate your attention. I really appreciate you, Joe, for more than just what you did here tonight. Thank you so much. Larry, same thing. Folks, we're really, really trying to advance what we're doing here and give everybody all the tools they need to help their patients. And that's what we're all about. So thank you so much. I appreciate your time. If you have any questions that you think of later, feel free to email myself, Larry, or Joe, and we'll get you the answers. So Dynamite, we'll see you Thursday.
Thank you, gentlemen.
All right. Yep. Thanks, guys.
It's Justin. Thanks for giving me flashbacks to medic school, and I'm having to go talk to a therapist now. That cellular respiration slide came up, and I'm like, yeah, here I am back in Vietnam.
Hey, let's talk about Krebs cycle.
Yeah,
dude, I started hearing Fortunate Son and Huey's about that point.
Too funny, Justin. All right. Yeah, Jace. Jace Malikoff.
I saw it go by. Are there any questions out there? I thought I saw a hand up. Okay.
All right. I'm going to sign off, guys, and I'll be on Thursday to hear Glenn Keating. I'm excited to listen to Glenn. So, Matt and Larry, if you guys need anything in the meantime, let me know. I got an email or two already, and so what I'm going to do, you guys, Matt, if you want to, I'll send it to you and Larry too, but this file is way too big to do it anyway, but I'll post it on my Google Drive, and I'll send you guys the link, so that way, Matt, if you want to pull it down and if you want to post it somewhere or whatever, feel free. Larry, just so you have access to it too.
Hey, Joe, before you go, it's Will Brando.
What's that?
It's Will Brando. Before you go, I got a question for you.
Yes.
Hey, I can't remember if it was at the Mahoney County Fire Chief Symposium a few years ago or if I'm just having flashbacks at medic school. You had an incomplete spinal cord lecture that you did.
Yes.
Do you still have those slides by chance?
Yeah, I'm actually going to do that, as the CNS injury is actually going to be incomplete spinal cord and spine motion restriction. I'm going to do that as part of this. Yes.
Okay.
Yep. And I'll get them to you, once I get them, once I do it, because I'll see if I have to update anything. But once I do it, I will get those to you too. Just send me an email.
That would be awesome. Thank you.
Yep. You're welcome.
Matt, I know I'm the old guy, but this is the right website for now on.
That's correct, Dan.
Thank you very much.
Freaking got his EMT card when they were still stone and chisel, man. Thank you, guys. That was a great lecture.
Great. Thank you.
Pretty much there, Tom.